to other classes. And then he found that there was no interaction about the 6 physicians in GH. Then he was the first person who started a meeting called Friday meeting, physicians meeting. He was the first person. There used to be a once a month meeting called general meeting, where all the surgeons, physicians came and sat and listened to cases in which they were not interested. But this meeting was focused every Friday. Everyone, he walked in at 2 o'clock, everybody walked in before that. All the interesting cases of 6 units were present there. Then we knew other physicians as well, their capacity, their cases. But more than Chennai, and we never interacted with anybody else. So he brought them together once a month. There was a dinner meeting in Dasa Prakash, where all the colleges took part. It was one meeting because we met other people as well. And cases were presented.
Sorry for the interruption, sir.
Can you hear me?
The screen
Can you hear
is
me?
not full, sir. Yes, sir.
Sorry?
The screen is not full, sir.
Not good?
Please keep it on. Yeah.
No, not full, sir. It's
Full,
partially.
how do I do? I don't know how to do that.
No,
Yeah,
sir.
now it's okay, sir.
Now it's okay, sir.
Okay.
Okay.
So that meeting was, in charge was another famous man, Dr. Vishwanathan, who started the upgrading of treatment of diabetes. Diabetes is being treated by GPs and DPs and BPs. He made it a specialty in Stanley Hospital. I owe him a special gratitude because he looked after my mother when she developed hemiplegia. She used to come almost every day to see her. We are living in Tandiarpet then. So you see some of these iconic people, his picture I don't have because Vijay has that. And some of the things that you see today are the work of those people. This Dr. Nation, you see the third person in the row here, he had an interesting, he was very, very good at coining things. And for myasthenia gravis, he coined a word called chapati test. Sorry, my hand was covering it. Sorry.
Yes, sir.
So we said, what chapati test? He said, South Indians don't know how to make chapati. And then you have to chew and chew and chew. Myasthenia cannot do that. So he said, it's called chapati test. And he died in Coimbatore. He made a big name there. He was such a good friend. So jolly and so knowledgeable. Dr. Janardhan, of course, you know, he became the director of medical services. He helped everyone. He came from anatomy department. I was there when he was an assistant there. He used to go around in the floor. See, what I'm trying to say is the preclinical people also made their name, not just clinical people. Can you still see the photograph? No.
No, sir.
So, sorry, what happened? Akshay? I lost it. Sorry. Got it back. So we are talking of this person. He was the first person.
Sir, we can't see
Can
you,
you hear
sir.
me?
No, sir, I can
I
hear
can
you.
hear you, can't see. Now you can see. Now you can see.
Yeah, okay. Now, gone again.
Nine.
Sir, I think your fingers are coming, sir.
I don't know what
Yeah.
to do. Now?
Yes, sir.
Yes, sir.
Okay. In those days, MBBS exam was not so easy. 100 people appeared, only 20 passed. So considering that, Dr. R.S. started revision classes. 3 months before the exam, he would stay back and take a class in his ward at 2:30 p.m. after lunch. He'll have a sparse lunch in his room and come back to the ward. And the ward was full of MBBS students. Not only MMC, SMC used to come, then Rawapeta people used to come. So ward would be full, more students than patients there. And you will revise subject by subject. If many of us passed, it was because of that one. There was one more person who did that, and that was Sadasivam in surgical science. No other physician did this extra work. Their work was over at 1 o'clock. They will all go home and practice. That kind of person who stayed back, he could have made much more money, he had gone away. But he taught the students. 3 months before the exam, he would start this. So we are talking of that person's birthday. It is very significant because his birthday was on 4th August. My father's birthday was 5th August. My father's birthday was celebrated in great strength, great style. So it was good fun to have these two things together. He was particularly fond of me. When I came back from England and he gave me a ward, I was looking after typhoid ward. One ward full of typhoid. We have emerged from that kind of situation in our country. One full ward of typhoid. There was one full ward of tetanus in those days, in 60s. No, I came back in 57. 57. He loved me. He treated me so well. And I have been to his house so many times. His grandson had muscle disease. He took us to his Chunampet village. He took part with everyone in sports, in other activities. So that kind of a person is our legacy. So let's all pay respect to him. Thank you, Velu.
Thank you very much, sir.
Thank you, sir. Thank you, sir.
So, Rian,
Thank
can
you,
I have a
Nataraj.
word? Can I
Sir.
have a word?
Yes, sir. Please, sir. I thank Professor CUV for giving the privilege to host this year's annual CME in honor of the venerable and dear Professor Ratnavel Subramaniam, which is held every year in the first week of August to synchronize with his birth anniversary, which is on 4th August, as Professor G.A. just alluded. I thank Professor CUV, sir, and request you to give the welcome address and start the proceedings. As you know, sir, the first case will be from Institute of Neurology, and Dr. Srivardhan will be presenting, sir. So you can take over, sir. Professor CUV, sir, can take over, please.
Before you start,
Yes, sir.
Velu, Natarajan,
Sir.
I will beg your pardon. I may leave in 1 hour's time.
Yes, sir.
I have some family commitments, so I don't want to disturb you then. I'm telling you now.
Thank you, sir. Thank you very much.
God bless you all. God bless you all. Yeah.
Thank you, sir. Thank you, sir.
Thank you, Dr. V. Natarajan.
Thank you so much, sir.
Dr. Natarajan,
Thank you,
is the
Raja.
Natarajan is the organizer, sir, of this monthly meeting.
Sir, Professor CUV
Yes.
only directed me.
No, and he was kind enough to give this chance to Chennai this year. This month. Last month it was Tirunelveli, that Zahir was in charge. Before that, Salem, I was in charge. I don't see the pictures now.
Next
Hello?
time we'll have it, sir.
Yeah, we don't see the pictures.
Yes, sir.
Ian, we don't
Yes,
see
sir.
the picture at all.
Jyoti, can you have sir's picture, please?
Everybody said, I don't see anything.
Sir, he will share by own, sir. There is option. Sir, there is
Share
option.
option.
Share option is there, sir, in the
Can
bottom.
we have one picture with all on the frame? I can click it. Can she do that? I've not seen so many people for such a long time.
I don't think so.
Can
Jyoti
she do
Pass,
that?
is it possible to get everybody into one frame?
Small,
Sir,
small photo.
We
The
can,
faculty.
Grid mode, sir. Grid mode.
yes, we can have a view option, sir. Gallery view is there.
Okay, Raja. Okay.
In the top bottom right. Sorry, top right.
நீங்க ப்ரொஃபசர் சியூவி வீடியோ கொடுங்க.
Not to be seen being.
சார் ப்ரொஃபசர் சியூவி வீடியோ கொடுங்க ஜோதி.
Sir, it's already given, sir.
இல்ல சார் அவர் வந்து வர மாட்டேங்குதுன்றாரு.
Sorry.
அதை யாராவது கனெக்ட் பண்ணி விடுங்க. ஒரு எதை ஷேர் பண்ணணும்ன்றதை கனெக்ட் பண்ணி விடுங்க. இல்ல அவங்க ஜெயஸ்ரீ இருந்தாங்கன்னா கனெக்ட் பண்ணிடுவாங்க.
Jayashree is there. Jayashree is sitting next to me.
Madam, you can't connect his video, madam.
Recording in progress.
மேடம் சாரோட வீடியோ கனெக்ட் பண்ணி விடுங்க மேடம். தேங்க்யூ.
Hello.
Yes sir, you are audible sir.
Am I seen that?
ஜெயஸ்ரீ மேடம் ஸ்டில் வீடியோ போயிடுத்து திரும்ப.
Is it better now? Audible to me?
Yes sir,
Audible?
visible and visible sir.
So I want to thank Professor Natarajan profusely because he has allotted Chennai for this month at my request. And the last 14 years, we have been conducting difficult cases forum every year, 3 or 4 in number. And this scope, one of these meetings in August will coincide with Professor R.S. birthday. And Professor Chandras has always spoken about Professor R.S. Sometimes Professor Saradaman has taken part in that. And wonderful cases are presented. And I gratefully acknowledge the people who are wanting to present here. Dr. Dinesh Naik, Dr. Malcolm, Dr. Prasad, Dr. Meenakshi Sundaram. We have the advantage of having the Secretary of the Indian Academy. We have the advantage of having the Secretary of the Indian Academy of Neurology with us, and he will project our ideas to the Indian Academy of Neurology to conducting these meetings. Meenakshi, is it okay?
Yes, sir. Yes, sir.
Then last meeting that we had,
In a tiffin போட்டுக்கமா.
last meeting that we had a wonderful case by Dr. Dinesh Naik. A boy was tapping with his legs on the floor, and it is almost like the beatings produced by Sevamani, and I thought it is functional. But the Naik showed an epileptic focus which he ablated and cleared the whole lot. Such wonderful cases. There, Vishwanathan used to present refractory cases, super refractory epilepsies, and autoimmune disease. Meenakshi has presented once an autoimmune encephalopathy. I think we have several interesting cases. I'm sure we are going to have more interesting cases this time. And acknowledge Professor G. Arjundas for having come here. Thank you, sir. and Professor Zahir Ahmed for participating. So we will have the case discussion. Professor Vian, you can initiate the case discussion.
Sir, it's you to take over, sir. It's
No.
Dr. Srivardhan from the Institute of Neurology, Professor Lakshmi Narasimhan's unit, sir. He is presenting the
Yeah.
first case, sir. Srivardhan, you can go on.
Yes, ma'am. Yes, sir. Yes. So is my screen visible, sir?
Yes, please.
Good morning, esteemed faculties and professors. At the outset, I would like to thank the organizers of this meeting, as well as my director, Dr. Lakshmi Narasimhan, for having given me this opportunity. I also extend my gratitude to the professors, faculties, and colleagues in the Institute of Neurology who have helped me in working up this case. So today's case is an interesting case from the Institute of Neurology. It is Occam's razor versus Hickham's dictum. The patient was a 13-year-old girl from Chennai, a right-handed individual doing a 10th standard, born of a non-consanguineous marriage, and the history was provided by the mother. The chief complaints which the child was brought to our institute included unsteadiness of gait for the last 3 months and tremulousness of both hands for the last 3 months. The child is a known case of seizure disorder on treatment. She was taking carbamazepine, levetiracetam, and clobazam for the last 5 years. She was apparently doing well till 3 months back when a mother noticed unsteadiness of gait. Initially, it was present only while walking fast or running, and it was associated with imbalances and swaying to either sides, tendency for the legs to cross, and associated with falls. Later, even while walking normally, she had a tendency to sway to either sides. Her mother also noticed that when she used to get up from sitting or lying down position, she would sway and adjust herself. Over the next few weeks, she would have frequent falls, 1 to 2 per day, and mostly to the sides. The child does not complain of any associated giddiness or spinning sensation, nor was there any cortical sensation while walking, and there was no suggestion of buckling of knees. Almost at the same time, the patient's mother noticed tremulousness of both upper limbs, and it was primarily present when she was attempting to move her limbs or while using an object. This was not associated with any sudden flinging movements of the limb or brief movements involving the entire body. Due to the pandemic situation, she was attending online classes, and her mother noticed that whenever she was holding her pen, she had difficulty in holding it properly, and it was associated with a change in her handwriting, which became slow and clumsy. Her mother also noticed changes in her speech. She describes her speech as a low volume speech with frequent pauses and being more monotonous. She doesn't give any history suggestive of a harsh or a straining quality of speech or speech associated with the nasal twang. There is no history suggestive of any impairment in comprehension or understanding what others were telling to the child. There are no episodes of impairment of consciousness, drowsiness, or episodes of non-responsiveness. According to the history provided, there was no impairment in the activities of daily living, and there was no history of any slowness of activities or staring look or abnormal movements at rest. There are no history suggestive of any cranial nerve symptoms, no history of floppiness of neck, difficulty rolling in the bed, difficulty in breathing or orthopnea, no feature suggestive of motor or sensory symptoms or bowel and bladder involvement. At 7 years of age, the parents, the mother of the child is a teacher working in the same school where the child was studying. They noticed that she was not able to read and write properly. They are basically Tamilians who are living in Maharashtra, and they speak both Tamil and Marathi in their house. Her mother noticed that she was able to communicate in Tamil and Marathi normally, and she was able to understand English, and she was able to answer in broken sentences. However, she had primary abnormality in reading all the 3 languages. Other than that, there was no other behavioral abnormalities. And she was evaluated for the same. And during that evaluation, an asymmetry in the size between the right and left upper limb was documented. And she was told to have a probable infantile hemiparesis. But the child had no symptoms, and she was still using the right hand as the dominant hand. A formal psychological evaluation was reported to have features consistent with dyslexia. She was offered psychological counseling and therapy, following which she had improved significantly. She is now able to read and write Tamil and English with some difficulty. There was no history suggestive of any poor scholastic performance, and she would be able to secure anywhere in the top 20 ranks in a class. And her mother attributes that the slowness in reading was responsible for her inability to score higher, and they were even planning to get a scribe for her public exams. At 8 years of age, in the school, her teachers noticed that she would have episodes of inappropriate behavior, like pulling her frock up, staring at people with an abnormal face, either with a protrusion of tongue or smacking of the lips. She would not be able to recall the event, and she would continue the routine activity which she was initially doing. On evaluation for the same, the parents said that initially it was attributed as behavioral changes associated with dyslexia, and they were not given any particular medications, and they were just reassured. And she continued to have similar episodes for almost a year, with around 1 to 2 episodes per month. And a year later, the patient complained of an abdominal discomfort, nausea associated with crying, followed by altered behavior lasting few minutes. And during those altered behavior, the mother noticed that she had abnormal orofacial movement and abnormal posturing of the left upper lip. And following this, she was diagnosed to have features suggestive of complex partial seizure, and an MRI done at that time was reported to have right mesial temporal lobe sclerosis. She was started on carbamazepine and clobazam initially, following which she had an improvement. And episodes became less frequent with once a month or bi-monthly. Over the last 4 months, she had no seizure. Around 3.5 months back, prior to the onset of current symptoms, the patient had an episode of fever lasting for 3 days, not associated with chills or rigors. There was just cold, running nose, fatigue, and myalgia. And she completely recovered 3 days later. But the parents noticed that all these symptoms started roughly 15 days after the onset of fever. The child was born by a normal vaginal delivery at term. The antenatal period was uneventful. In the perinatal period, there was poor crying and respiratory efforts, for which she was kept in NICU for 3 days, and she was discharged on day 7. There was no history of fever, poor feeding, feed intolerance, or jaundice in the neonatal period. At around 6 to 7 months of age, the child had high spiking fever with vomiting associated with lethargy and poor feeding. She had high spiking fever requiring hospitalization for around 4 months. Between her 7th month to first birthday, she has been hospitalized continuously. And evaluation for all the infective causes were negative, and there was no response to empirical antibiotics. She was then transferred to the Institute of Child Health in Egmore, where she was diagnosed to have an infantile form of juvenile inflammatory arthritis and treated for the same with steroids. A record of those events showed the following parameters. The total leukocyte count was 24,000, platelet was 15 lakh, ALP was 978, CRP was 27, serum ferritin was 789, ANA was 1+, the remaining autoimmune parameters were negative. Ultrasound showed an hypoechoic lesions in the liver and spleen, and bone marrow biopsy showed occasional hemophagocytosis. Following therapy with steroids, she completely improved, and her routine activities fully recovered. At around 11 months of age, during this process of hospital stay, she had an episode of GTCS associated with high spiking fever, which was attributed as a febrile seizure, and she was advised only clobazam prophylaxis during fever. MRI brain done at that point of time was reported to have multiple T2 hyperintensities in bilateral basal ganglia and centrum semiovale, and it was inferred as probable infarcts. We don't have the image at this point of time, only the report was available. She attained the routine milestones normally. There was no history suggestive of any mental impairment, language problem, motor or social skill. Till 7th year of age, when she had a learning difficulty, which was later diagnosed as dyslexia. There are no other episodes of fever, joint pain, photosensitivity, alopecia, oral ulcers, hematuria subsequently. Her mother said that all vaccines were given later appropriately as advised by the pediatrician. But she is not able to recall what are all the vaccines which are given or missed in the first year of life. And history provided by the mother about the milestones were essentially normal, and there was no history suggestive of any developmental delay. 3-generational pedigree chart shows there is no history of any other neurological illness in the family, except for the father, who had 2 episodes of childhood seizure. He is currently seizure free. Probably they were febrile seizures because the last episode was at 4 years of age, and is not on any anti-epileptic therapy. So to summarize, at the end of history, we have a 13-year-old child, a known case of dyslexia and focal seizure with impaired awareness, who was brought with 3 months history of progressively worsening unsteadiness, swaying, tremulousness, impaired gait, frequent falls, and difficulty in writing, which all followed an event of febrile illness. In a child with history of neonatal respiratory distress requiring admission in NICU for 4 to 5 days, with the febrile illness labeled as an infantile form of juvenile inflammatory arthritis for several months in the first year of life, with normal motor, social, and language milestones, with no feature suggestive of cognitive impairment, except for dyslexia, weakness, sensory symptoms, or autonomic dysfunction. At this point of time, we were trying to analyze the individual symptoms. The first symptom was a seizure disorder. Was it a family history? Was it familial seizure because there was family history of seizure, or was it unrelated? And apparently the developmental milestones are normal. Whether dyslexia has to be considered as an isolated event, or whether it should be put under the umbrella of cognitive impairment. And then we had history suggestive of progressive unsteadiness, swaying, and tremulousness and gait abnormality, all of which suggest a probable cerebellar ataxia due to cerebellum or its connection abnormality. Coming to cerebellar ataxia, in this case, it can either be inherited or acquired causes. Among the acquired causes, it could have been an antiepileptic drug toxicity because she was on carbamazepine. It could have been a demyelination or an infectious parainfectious pathology because it followed an episode of fever with myalgia, fatigue for 3 days, and the events developed 15 days after the inciting fever. It could be a metabolic or a nutritional pathology. It could have been a structural pathology. And we also wanted to consider the autoimmune pathology in a subacute ataxia because the child had a definite history of an infantile form of juvenile inflammatory arthritis in the first year of life. Coming to inherited causes, we need to approach as whether it was a cerebellar or cerebellar plus syndrome. And in history, the presence of dyslexia, scissoring of gait, and seizure suggested that probably we are dealing with a cerebellar plus syndrome and not a pure cerebellar syndrome. And the major root words we had for approaching in this case was ataxia plus seizure. And the review of literature showed these 5 major group of disorders which can have this combination of ataxia with seizure. They could have been channelopathies, metabolic disorders, storage disorders, mitochondriopathies, and other hereditary disorders. But unfortunately, our patient was not having any of the characteristic features of any of these disorders. Neither were the ataxia episodic, nor was there significant cognitive impairment, nor was there significant motor impairment to suggest any of these disorders at this point of time. So to proceed for the examination, the child was conscious, oriented, well built. There was no pallor, icterus, cyanosis, clubbing, lymphadenopathy, or pedal edema. The vitals were normal. She had no features of organomegaly or thyroid enlargement or features suggestive of hypothyroidism or nutrition dysfunction. There was no external markers of any syndromic causes of cerebellar ataxia like facial dysmorphism, café macule, tendon xanthoma, ocular telangiectasia, or evidence of ichthyosis. Mini-mental scale examination showed abnormalities in the attention and language abnormalities with a total score of 23 out of 30. In the frontal lobe, she had significant abnormalities in the frontal lobe function, and their frontal assessment battery was only 3 out of 18. Coming to parietal lobar functions, in the dominant hemisphere, she had impairment in praxis. She had impaired finger naming. She was able to do simple calculation with the pencil or pen and a paper, but she was not able to do complex calculation like multiplications. Reading was preserved. On the non-dominant side, there was impairment in clock drawing test. This was the clock drawing which the child had done, and there was some perseveration here. She had marked 6 twice. The time was advised as 11:10, but she had marked the random time, and she was not able to differentiate it as a small limb or a large limb particularly. Coming to the occipital lobar functions, it was normal. There was no evidence of optic ataxia or oculomotor apraxia. Language assessment showed impairment in fluency, impairment in repetition with the preserved comprehension. There are no naming abnormalities, no paraphasias. Writing was impaired. It was very slow, but reading was normal. In the memory domain, she had significant impairment in memory. She was not able to recall what she had for breakfast, not able to retrieve a story with impairment in visual memory. A remote memory and semantic memory were preserved. The primary abnormalities involved only the recent memory. Coming to cranial nerve examination, the first and second cranial nerves are normal. Fundus did not show any evidence of pigmented changes or cherry red spots. In the 3, 4, 6, ligand and extraocular movements are normal. She had hypometric horizontal circuits, broken pursuit. There were no obscureness. Rest of the cranial nerve examination was normal except for presence of jaw jerk. In the motor examination, the child had a thin build. There was no muscle wasting or fasciculations. She had difficulty in standing without support because of the ataxia. She had a tendency to sway to either sides, left to more than right, with an abnormal posturing of the neck, which is not fixed. There are no contractures or muscle hypertrophy, no calf atrophy or skeletal deformities. There is a 1 centimeter difference in the bulk between the right and left side, the right side being lower, and the right thumb was smaller compared to the left thumb, and she was using the right hand as the dominant hand. So this is a picture showing the abnormal posturing of the neck. She had a cervical dystonia. Coming to the tone, it was predominantly spastic, both in the upper and lower limb. Power was essentially normal except for mild weakness in the hand grip. Coming to superficial reflexes, corneal, conjunctival, and gag reflex are normally present. Abdominal reflex was absent in all 4 quadrants. Anal wink was present. Bilateral plantar were extensor. All the deep tendon reflexes were exaggerated. Trapezius reflex was brisk, and she also had jaw jerk presence. Jaw jerk and pouting reflex are present in the pathological reflexes. Cerebellar examination showed impaired finger nose and finger node test bilaterally, left more than right. impaired heel niche interest bilaterally left more than right with dysdiadochokinesia, intention tremor and pause pointing with rebound phenomena. She had gait ataxia with impaired tandem walking. There was no truncal ataxia. She had no nystagmus or titubation. In the extrapyramidal system, she had hypometric saccades with broken pursuit. There was a non-accommodative glabellar tap with a reduced blink rate. She had bradykinesia and cogwheel rigidity bilateral. And there was a cervical dystonia and right upper limb dystonia. There was no neutral position or sensory cues which improves this dystonia or abolishes the dystonia completely. She had no rest tremor. She only had an upper limb intention tremor with the postural instability and an abnormal gait, primarily a wide-based gait, which was slow, with a tendency to sway to either sides, associated with fall on either sides. Speech assessment showed a dysarthria, primarily of spastic type, with hypophonia and a monotonous speech. Sensory examination, bedside autonomic function test, and signs of meningeal irritation are not present. Examination of the spine and cranium was normal. At this point of time, to summarize the findings at the end of examination, we have a 13-year-old child, a known case of dyslexia and focal seizure with impaired awareness, who was brought with a 3-month history of progressively worsening neurological involvement following an episode of fever in the form of higher mental function dysfunction, hypometric saccades, spasticity with exaggerated reflexes, pathological reflexes, cogwheel rigidity, bradykinesia, dystonia, ataxia, gait abnormality, and intention tremor without any sensory or autonomic nervous involvement, with an history of neonatal respiratory distress, an infantile form of juvenile inflammatory arthritis in the first year of life, with a normal motor, social, and language milestones. So if we analyze the structures affected, it's the prefrontal lobe, parietal lobe, temporal lobe, and their connections, and memory domain impairment. There's evidence of bilateral corticospinal tract involvement above pons, bilateral cerebellar hemisphere or its connection involvement, basal ganglia or its connection involvement bilaterally. So at the end of examination, the extra clue which we got is prominent pyramidal and extrapyramidal involvement, which was not provided in the history.
Srivardhan,
Yes, sir.
You stop here, and
Yes,
I just
sir.
wanted the discussion from the floor. The origin, you missed out 2 things. One is a febrile seizure and episodes of typical complex partial seizure on multiple AEDs in your summary.
Yes, sir. Yes,
So
sir.
this, sir, this is the presentation, sir. I want the floor to give us some diagnosis so that before we let the final diagnosis, I just wanted.
Do you have videos of the patient, please?
Yeah, we have
Yes, sir.
videos, sir. So before
Can you play?
the videos will during her stay, one critical feature which she developed has really made us look into this. We can show a couple of images. The video, I want to play it last, sir. Video will
Welcome, Lakshmi. Welcome,
Lakshmi,
Yes, sir.
Welcome.
Yes, sir.
Lakshmi, before the specialists and the pundits come in, as a journalist, can I give my thoughts about it?
Yes, sir. Please.
Sir, you
Okay.
are the super specialist.
Sir,
Sir.
you are the
No,
you are the
no,
teacher of all
please.
teachers, and you are the.
Let's leave that alone. Let's leave it alone.
Yes, sir.
Srivardhan, I
Yes,
would
sir.
go for the Occam's razor, as usually I do. Let's keep things simple. Here's a patient who had an insult early in her life, characterized by infantile hemiparesis that clicks it that she had a left hemisphere dysfunction. The rest of it, the seizures, the right MTLE presentation, and the right MRI appearance all confirms that she did have a left hemispherical involvement earlier, which gave her the infantile hemiparesis and the seizures. So that is one part. The rest of the neurological and probably the so-called dyslexia or reading, writing that goes along with that involvement. Now, the rest of the problem was only of 3 months duration. And in the 3 months, she has a progressive encephalopathy, which is characterized principally by cerebellar and extrapyramidal involvement, perhaps with a little less cerebral or cognitive involvement. You said that her MMSE was 23/30, and she did have an involvement earlier itself because of the dyslexia. So we are not sure how much of cognitive involvement was there added on now. But maximally, it seems to be cerebellar and extrapyramidal with some amount of added cognitive involvement also. So there are 2 problems here. One is an earlier seizure, infantile insult producing the seizures which characterized, I mean, initially she had febrile seizures and later went on for complex partial seizures, as is to be expected. So that part is fairly clear. Now the second part, encephalopathy, what initially could be considered was, as you pointed out, AED toxicity. But AED toxicity, she was on carbamazepine, clobazam, and levetiracetam. I do not know why levetiracetam was added when the seizures were reasonably under control. You said once in 4 months only she was getting it. But anyway, we leave that apart. So if we consider an AED toxicity, it has to be carbamazepine toxicity. And carbamazepine toxicity to produce extrapyramidal and an absence of nystagmus. You made a mention that there was no nystagmus. So with the absence of nystagmus, rest of the cerebellar features and the presence of extrapyramidal features and this being progressive in the last 3 months, I would not consider an anti-epileptic drug induced phenomena here. So we'll have to look at something else in the background. And that is where what you said earlier, whether it is something which is provoking the cerebellar, not alone cerebellar, now it's an extrapyramidal problem. So we have to consider ongoing encephalopathy on the background of an initial left hemispherical insult with complex partial seizures as a result of that.
You say that the static encephalopathy followed, which was the initial insult, followed by a progressive dynamic encephalopathy of the recent one, the two diagnoses.
Maybe Lakshmi,
So
but
you want two baskets, sir.
that static encephalopathy was minimal. It was, you can't call it encephalopathy global term, because I would say that was a static insult which happened in early childhood.
Static insult. Okay, fine. Okay, sir.
Yeah, I would say it's instead of a global encephalopathy, it was a localized left hemispherical insult, and now she has a global encephalopathy which is progressive. This would be my analysis. And further on this, I would bring in the specialist, particularly pediatric specialist also is there. Yeah.
So the two, you're trying to tell that there are two distinct things. The recent one is different from the earlier insults.
No, Lakshmi. There are two compartments, two issues here. One, I have identified the cause. The second, I am not able to. The both may be linked. Both may be linked. This is why you are bringing in Hickham's dictum.
Yes, sir.
I opted for a discussion using Occam's razor, but obviously I cannot fix it on only that. So we have to look at the other side. We'll have to think at more complex involvements. So we come on to Hickham's dictum. And as far as the complex involvement is concerned, what is this progressive encephalopathy which ties in with the previous left hemispherical insult producing the seizures? I leave it to the specialists.
Anybody else, sir? Anybody else wants to say?
Vishwanathan is there, and others, of course, can participate.
Sir, Vishwanathan here. Sir, just I agree completely with Professor Natarajan. Only thing I was going to say was like it doesn't look like a global insult now because MSME, etc. It looks more like a basal ganglia stroke. Cerebellar involvement now compared to the gray matter involvement as such. And usually these things happen in children who get deposition of matter in the basal ganglia stroke wherever, or in mitochondrial disorders. These are the usual two disorders that cause either iron deposition or copper deposition. Of course, there are no other signs of copper deposition. I'm not sure if the initial insult or initial story is related to this. I think this may be a secondary involvement. That's my feeling from the history. And of course, an MRI would give us a clue as to what is happening. The thing against a mitochondrial disorder here is that there is no involvement in the eyes, and there is more involvement of the basal ganglia than the cerebellar signs, is what I feel, because of the persistent dystonia and the cogwheel rigidity rather than the cerebellar involvement. I'm not sure, and the intention tremor. That's my feeling, sir.
Vishwanathan, please.
Sir, can I?
Yes, just one quick question to Vishwanathan.
Yes, sir.
See this second problem, the encephalopathy progressive,
Yeah.
this is said to have followed an episode of fever. So would you give credence to it or discount it? Could there be any autoimmune process going on?
That is a possibility, sir, but I think it is less likely because I think the way they have described it and the story seems much more to be a progressive condition, and an autoimmune process many times I feel is not so rapidly. I mean, it's usually an event that happens and they may tend to appear to recover for some time and they may have a recurrence, etc. Whereas this seems to be a progressive phenomenon and with such severe bilateral pyramidal signs, obvious bilateral pyramidal signs, and it seems a little unlikely, sir.
Thank you.
Dr. Sahiti has said it could be NPTA, and Dr. Kailasam said that it could be heavy metal poisoning, and Dr. Dilip Maheshwari has said it could be NMDR autoimmune encephalitis. There are three.
Lakshmi, I would like to add one more thing. Lakshmi,
Yes.
I'm Anand here.
Yes, sir, please.
The episode following a fever with higher mental function, hypometric saccades, and extrapyramidal symptoms, Japanese B encephalitis to be considered.
So infective. Okay, fine. Very good, sir. Thank
Sir,
you.
one more. Can I speak, sir? One more
Yeah,
thought.
please.
Of course, yes, Vikash.
So, sir, here we have, as we, sir, rightly discussed, an extensive bilateral extrapyramidal involvement along with Parkinsonism and early dystonias and cervical dystonias on a background of a, sir, on a background of an insult, which happened definitely a left hemispheric insult. Now, at present, there were some episodes of episodic encephalopathy, whether it was drug or associated epileptic encephalopathy or the fever triggering the underlying problem. I think it was earlier, it is the same pathology going on here. I will go with the Occam's razor. In such conditions, when you have a spastic, bilateral extensive spastic sign, Parkinsonism and dystonia, with some MRI basal ganglia abnormalities in early children, we should consider infantile dystonia Parkinson syndromes like dopamine transporter deficiencies, number one. Number two, I would also like to consider in the juvenile or the early form of leagues and mitochondrial cytopathies as discussed in the group, sir. So I'll keep myself brief. These are the two possibilities.
Okay.
Infantile
Can
dystonia syndromes and
Hello.
Can I?
sir, please.
Hello. Can I speak?
Yeah.
Sir, can I, sir? Meenakshi Sundaram here.
Hello, can I speak?
Yes, sir.
Hello.
Meenakshi Sundaram, finish, you speak, and then I'll speak.
UMS first,
Sir,
Zahir sir second, and Vijayan is waiting. Vijayan third.
Okay,
Sir,
let everybody speak. No problem, I can wait.
Sir,
No, sir, you are going second.
Hello.
UMS, you are not audible.
Sir, you would go to, am I audible now, sir?
Yeah.
Hello?
Yeah.
Yeah, you're audible. You're audible now.
Yes, sir. We would go by the presentation today. This patient has primarily presented with a cellular ataxia with some Parkinsonism and dystonia. That's a presentation. The clinical presentation as of now would probably be one entity which would immediately come to mind when one says it's precipitated by fever is rapid onset dystonia Parkinsonism, which can be precipitated by fever, dystonia 12, DYT 12. But the point is, in the history, I think while summarizing, the point was that this child had a childhood absence epilepsy, because there was a specific note where they said that she would act and then she would just continue without being aware that she had anything. And I would think of that as probably a absence epilepsy that's probably happened in childhood. And now she has come on with difficulty in walking. She has spasticity, no doubt. What I would look for, there was a good discussion. One would be quite tempted to think about mitochondrial with seizures and all this. But for NBIA, I would have wanted more brainstem involvement as far as the dystonia is concerned. So that's probably one thing that's against. So what is this likely to be? Well, in my opinion, if the child presents like this with spasticity with cerebellar, with the childhood history of CAE, childhood absence epilepsy, the diagnosis one would consider, and I would want to see on video whether this is exercise-induced aggravation of the spasticity, then I would think of GLUT1 deficiency syndrome. And I will look for SLC 2A1.
Thank you.
Professor UMS, sir, can I ask, sir, like a bit disagreement here, sir. It's rather than a focal epilepsy rather than an absence epilepsy, sir. It could be a.
She had absence epilepsy.
Okay.
She had, and you can get anything. She had absence epilepsy. I think Srivardhan can probably show that slide where he says the child would behave. And there is a
Yes, sir,
specific
I
form
put that.
where he said that the child then would resume without any
But,
knowledge of what has happened, just continue with their activity. I think that word tells us it was probably an absent seizure.
Because what my point was, sir, that some of these posterior
See
cortex
the second line. See the second line
can-
is she would not be able to recall the event and she would start continuing the activity which she was initially doing. This, I think, is sine qua non of an absent seizure. And I think when you have a childhood absence epilepsy in the setting of all this, and on the video, I would like to see if this is exercise-induced aggravation. And then I would like to think of GLUT1 deficiency syndrome.
Sir, at that point of time, one of the senior epileptologists has made a diagnosis of complex partial seizure for this.
But this line, no, Lakshmi, I would be very.
We have given whatever verbatim what they have given, told us.
UMS,
Yes, sir.
please look at the ictal presentation. Don't go for the post-ictal. Look at the ictal presentation.
Sir, I would also be.
With an absent seizure.
Sir, she would not be able to recall the event is a specific thing that they have said. And that I think would not be a feature of a CPS, sir.
There is one more
Pulling her frock
possibility
up
in this condition,
with
whether ADCY5 also can present like this, in some of these.
ADCY5 would be more like dyskinesias that get aggravated in
yes.
the evening. They do not really present with such dystonias.
Dystonia, that's why, sir, the first possibility, dopa responsive dystonia, dopa receptor deficits, this was my first possibility.
That's dopamine.
Dopamine transporter
Fine,
deficiencies.
I would.
Sir,
Zahir, sir.
Hello, can you hear me?
yes, sir. Yes, sir.
Who's this? Lakshmi Narasimhan?
Yes, sir. I give you one clue, sir. This disease is close to you.
I try to summarize the whole thing in my mind. What does this patient have? This patient has a basal ganglia disorder. This patient has a cerebellar dysfunction. And this patient has intellectual disorder. With the whole thing sequencing into a left, probably the left hemisphere being more involved than the right hemisphere. And this is a progressive disorder. Now, to my mind, only 2-3 things come to my mind. One is, if I was it was a little older person, nowadays we used to call, what is this? Iron inclusive iron deposition disease.
NBIS. Okay.
Pardon me?
NBI, iron accumulation.
Yeah, that's one. I think a parent, I'm forgetting. Halloween-Spatz disease.
Okay.
Now, does Halloween-Spatz disease, how many have we seen? I probably would have seen 1 or 2. And there is a genetic preference to it. Now, that was one thing which was going in my mind, whether this is a Halloween-Spatz. 2, I can't I disagree with somebody who has said this could be a mitochondrial disorder, but I think you would have to demonstrate cardiac involvement and muscle involvement to say that it is a so severe mitochondrial disorder. 3, the transporter dopamine transfer deficiency, I have not seen and I have not proved, so I can't comment on. A general this thing I say, something which looks like Wilson's and has no K-F ring will fall into the category of Halloween-Spatz. However, today, anything can become an immune process disorder. That's the only thing which remains. Thank you.
Thank you, sir. Anybody else, sir?
Vijayan was waiting, I think.
Yeah.
Coimbatore Vijayan.
Sir, nothing, sir. As Professor KS usually calls this energy failure. Mitochondrial. Thank you, sir.
Okay. Then, Srivardhan.
Yes, sir.
Move on.
Sir, Professor CUV, sir, has anything, sir? He is the chairing.
No.
Sir, CUV, sir?
and the MRI.
Sir, can we proceed, sir?
Yeah, please.
Srivardhan,
Yes,
continue,
sir.
please.
So, like what everyone has discussed previously, this was our thinking process, and this was the etiology which I had kept in mind. Why leukoencephalopathy is first is because even though all the symptoms followed a fever, it is not always necessary that it has to be infection or demyelination. There are reports that even a relatively silent leukoencephalopathy can follow a sudden stressor event. So that was also considered along with mitochondriopathies. Autoimmune encephalitis was very well in our diagnosis because it is potentially treatable and there was a definite history of an immune-related process somewhere in the past. And then neurodegeneration followed by infection. This was the etiological diagnosis which we had in our mind at the point of initial assessment. So again, going with the root words of ataxia with spasticity, we tried to look if any of these syndromes can fit in, but our patient did not fit into any of these features. And now comes the most important thing. She was admitted in hospital and she was almost with us for 3 to 4 weeks. During the course of hospital stay, she developed a relentless progression of the disease. She progressively worsened with bradykinesia and rigidity. And within 10 days or 2 weeks, she developed severe dysphagia with drooling of saliva requiring Ryle's tube administration. She developed multiple episodes of brief, jerky movements of all 4 limbs, which are periodic.
SSP.
These were periodic myoclonic movements which are proximal and not stimulus sensitive. They persisted and progressed in spite of stopping carbamazepine. At this point of time, we also tried to rule out mitochondriopathy by doing a CSF and serum pyruvate and lactate. After documenting it was normal, valproate was added. So she was on levetiracetam, valproate, clonazepam, and clobazam, in spite of which the myoclonus progressed. And during the 3 weeks, she ended up almost in a case of severe dysarthria with mutism with preserved consciousness. I'll show a couple of videos. This was around day 2 or day 3 after hospitalization. She was relatively well preserved, had a cervical dystonia with tilt to the left side. You can also see the infrequent blinking with the mask-like facies.
Did she have the jerk of SSP?
This was a myoclonus, sir.
Yeah, she had SSP like jerks.
Yes, sir. Very slow.
Slow myoclonus.
But it was initially it was very infrequent, sir. She used to get it very infrequently.
What was it? Stimulus sensitive?
No, sir. It was not stimulus sensitive, sir. And this was a week later, roughly. The dystonia was persisting. She had the Parkinsonian findings, and she continued to have the myoclonus frequency had slightly increased beyond. So at this point of time, with the action of myoclonus, we had to revisit our diagnosis, and we still consider Wilson's disease as a possibility here because it was potentially treatable, even though there are multiple red flag signs against it. Then mitochondriopathies, progressive myoclonic epilepsy syndromes, leukoencephalopathies, autoimmune encephalopathies, and slow viral illnesses.
EEG.
Yes, sir, I'll come to that, sir. So we tried, this was from the Journal of Movement Disorders, an approach to ataxia myoclonus syndrome. So applying this, it was an epilepsy with infrequent seizure. Our patient had predominant extrapyramidal involvement, which essentially localizes to most of the myoclonic epilepsy syndromes. And this was the first MRI done in 2016. We only had a couple of images available with us. The report was right mesial temporal lobe sclerosis. You can see a bilateral medial temporal lobe hyperintensity, right more than left, with an dilatation of the temporal horn of the right lateral ventricle. And this was the MRI done at this point of time during our hospitalization. The T1 sagittal was more or less normal, except for some subtle hypointensity involving the white matter region. This was the T2 axial cut, which showed bilateral white matter hyperintensity involving both the subcortical white matter as well as the deep white matter. And we can see it extending along the internal capsule, external capsule. This was the flare coronal showing hyperintensities of the bilateral cerebral hemisphere, but there was not much of a brainstem or cerebellar involvement. The primary pathology was supratentorial, and there was no associated contrast enhancement. Shall I show the investigation, sir?
Yeah, proceed. I think we are running short of time.
So the routine investigations were normal, and the ECG did not show any evidence of conduction defects. Echocardiography was normal. Pure tone audiometry was normal. ANA and anti-TPO and other inflammatory markers was normal. Slit lamp examination was normal. There was no KF ring, but serum ceruloplasmin level was 14, with the cutoff being 18. But the 24-hour urine copper was normal. So we were not very convinced it was Wilson's disease, even though we had kept it in our mind and we are planning to go for a genetic analysis based on the findings of other investigations. CSF analysis was showing a mild elevation in the protein. Rest of the examination was normal. Anti-aquaporin 4 antibody, anti-MOG antibody, and the entire autoimmune encephalitis panel in the serum and CSF was negative. This was an EEG done outside around 3 or 4 months back, which was reported as an focal epileptiform abnormality over the left temporofrontal region. But in hindsight, had they reduced the sweep speed, I think this would have a more of a periodic pattern. And this was the EEG done in our institute, where we are able to demonstrate periodic discharges, roughly at a frequency of 1 discharge happening between 7 to 10 seconds. And I'll play this video EEG recording. There was a periodic discharge, but some of them were associated with the myoclonus. Not all of them were associated with myoclonus. Some of them were associated with the myoclonus.
So the whole thing is that the telltale myoclonic jerk came only 3 days prior to her discharge. Until then, she never had myoclonus at all. After the advent of the myoclonus only, our diagnosis lines, everything got changed. Okay, go to the next one.
As sir mentioned, it was the myoclonus which helped us in clinching the diagnosis. And, sir had already mentioned the diagnosis as well. We did a CS of measles antibody titer, and it had come as 625, and all the features are actually fitting into a diagnosis of subacute sclerosing panencephalitis. So coming to this case, we had labeled it as outcomes racers versus incomes dictum because we are trying to fit everything into a single diagnosis, and that is why we ended up with a diagnosis of mitochondriopathy, a leukodystrophy at several points of time. And even now, we believe that the initial manifestations could have been a component of SSP or measles. Seizure as an initial manifestation of SSP, and the childhood fever part as an initial manifestation of measles infection. Or if you are invoking the Icham's dictum, sorry, sir. If you are invoking the Icham's dictum, the childhood fever and seizure are probably unrelated to SSP. In addition, the child has probably developed almost an acute fulminant form of subacute sclerosing panencephalitis.
Excellent. Thank you.
Yes, sir. And just 2 things. This is a review of literature. Probably there are 6 or 7 cases of childhood measles infection which presented like an hemophagocytic lymphohistiocytosis, and majority of them have a favorable outcome with just immunomodulation, except for 2 of them. So there is no way of proving or disproving it, but we are not sure whether the initial infection which she had between her 7th month to 1st year of life was probably a measles associated hemophagocytic lymphohistiocytosis from which she had recovered at that point of time, but the measles virus has been dormant to progress into a subacute sclerosing panencephalitis. No. Thank you, sir.
Sir, one important point is that JRA, like the juvenile inflammatory arthritis, at that point of time, there was documented evidence of hemophagocytosis where there is a window of opportunity for treating this for prevention of SSP, sir. This is one important point which I just wanted to. One of the important take-home message of this entire meeting is she had an inflammatory arthritis which present with the hemophagocytosis, a point of which where immunomodulation could have helped in prevention. I do not know, but most of the things which are reported there, the hemophagocytosis associated with measles, were treatable. The follow-up studies are also shown that fairly. So I thought that is one point which is take home. And secondly, we searched the literature where complex partial seizure or any other point of seizure presenting as SSPE, there are not many of reports. And my one more question is, what is the reason for the periodicity of the various things in SSPEs? These are three things which I just wanted to know from the floor. Thank you. Thank you for your attention.
Then how would you anticipate and treat this patient earlier with the disease modifying drugs? That's a big question you are answering. At that point of time.
Oh, Lakshmi.
Yes, sir.
Did you at any time in the course of this disorder,
yes, sir,
earlier or middle, ever think that this could have been an SSP?
No, until I saw the myoclonus.
No, not the myoclonus, Lakshmi. Yes, I think, I don't know, if we had done EEG much earlier.
That record we are not having, sir. Yeah.
You probably could have picked it up, and all this discussion would have been abrogated.
Yes, sir.
Don't you think so?
Yes, sir. The record we don't have.
Yeah, no, I agree with you. I'm not saying so. The only one thing I want to sort of, what shall we say, is, the rate. Nowadays, we used to think everything which looks like Wilson's, but does not have the copper metabolism challenges, is Hallowooden spots.
Okay.
But this may not fit into present these things, because so many immune modulated diseases come into this kind of a thing. So you have to keep in mind that something may be immune modulated.
Yes.
Thank you.
Thank you, sir. Thank you, sir. Thank you for your time and attention, sir. Thank you.
Thank you, Dr. Lakshmi. We'll move on to the next case. Dr. Dinesh Nayak. Hello.
Morning, sir.
Morning.
Thank you very much. And I will start off. Let me see if I can open. Sorry, sir, 1 minute. Yes, I'll start off. It's a great privilege, sir, to be here in this forum to discuss an interesting case. And the first case was absolutely brilliant. I mean, I was just so many learning points, and we can, get caught out even till the last minute. So that's what the learning curve is. Now I'm going to show a slightly different case, but something similar. From problem to solution on a razor's edge, and I'll tell you why it's a razor edge. And our pranams to the teacher of teachers, Professor Ratnavel Subramaniam. And again, salutations to the doyens of neurology, who are both of them here. It's a great privilege, sir. Today also happens to be the first death anniversary of my teacher and mentor, Professor Pranesh. So my salutations to him, wherever he is. So I'll start off now. He's a 31-year-old male who was younger of 2 siblings and was born normally. He cried soon after birth. His milestones were normal. At the age of 4, when playing, he fell from a height of 5 feet, fell on a spiked fence There was only some bleeding here, external bleeding, not from inside the ear, but there was no loss of consciousness. So, but that's a history that they have. That's the only thing, because about a year or so later, he started having unprovoked seizures, which began around 5 or 6 years of age. And those seizures are like this. They are right from that age till now. He always has the same kind of a feeling. Now he gets a kind of a tingling sensation and a feeling of tightness. He feels that the arm is getting tightened, the right arm and the hand. So these two become stiff and he feels some kind of a tingling. It's not pain. It is not paresthesia. It's not electric shock. It's not a negative symptom, but he feels some kind of a tingling. Now then the arm, he says, gets raised above his head automatically. And if he's in a standing position, he tends to fall backwards because probably his trunk also becomes a bit stiff and he may lose balance. And this may sometimes proceed to bilateral convulsive tonic-clonic seizures. And if these seizures usually last only for about 45 seconds or 30 seconds or something like that. But sometimes if it is prolonged for more than a minute in the same position, he gets a postictal weakness of the right hand for a few minutes and then he recovers. Interestingly, sometimes not associated with any of these, he feels he is not able to speak properly for some time, for a few, maybe about 30 seconds, 45 seconds. He can comprehend very well, but he's not able to reply. And he feels that, he's got some kind of a difficulty with articulation and he's not able to express at all. So that's the seizure type. So it's very important, the tingling sensation and the tightness of the right arm, and then the arm getting elevated above the head. And then that's the core of the symptom is that sometimes it proceeds to bilateral convulsive. Sometimes if it is more prolonged, he may get a postictal weakness. So that is something that we have to look at. And very infrequently or very rarely, he gets this speech arrest without any other feature. And that would last for about a few seconds and then he becomes all right with preserved awareness. Now, the usual frequency, you can see that from the age of 5 or 6, the frequency has been extremely high. He gets it almost every day. Or he may escape for a couple of days or maximum 4 days and he gets it. So that's a very high frequency seizure. Usually about 1 to 2, rarely he may get more than that. Sometimes 4 or 5 also he may get. Usually early morning at 4 o'clock, he may suddenly wake up from sleep. But usually, that's many times it has happened, but he also gets it when he's fully awake. The maximum seizure-free period in all these years of about 25 years has been 5 months. And that is very early in the course of the illness. So it's a very high frequency. And you can see that he has been resistant to, over the decades, he has been tried on every anti-seizure medicine, including the first generation, the second generation, and many of the third generation anti-seizure medicines. And so that's what it is. So on examination, he has no neurocutaneous markers. Higher mental functions are normal, speech is normal, power normal, sensations, both primary as well as cortical sensations, normal. No epilepsia partialis continua, plantars or flexors. So he absolutely doesn't have a single deficit. Fixed deficit is not there. So that is important. Now, for many years, he has been with us, and for the next 4 years, he was in NIMHANS. And you can see the dosages that has been tried out. Absolutely very high doses and inappropriate medication, appropriate dosages. And despite this, if he gets about 2 or 3 attacks every few days, that's a very high frequency. And because of the lockdown, he couldn't go to NIMHANS, so he's come back to us. And this is the dosage, because we had to stop the valproate just because he developed a type 2 diabetes. That's one, may be related or may not be. He became obese also. And the other thing is we were contemplating maybe he may require some kind of intervention. So that's why we changed over from valproate to lacosamide and zonisamide because he was getting obese. So some weight loss also may help. So this is the dosage, but nothing changed actually. The frequency remains absolutely the same. There's no change at all. Through all this, he has completed BCom and he has tried several businesses, but this is very frustrating for him because he's not depressed or he's not moody, but he's absolutely frustrated because he gets these brief seizures. Neuropsychological evaluation, he's got a fairly okay IQ, 88, and both verbal and performance IQs are almost equal. So there's not much difference between the left and the right hemispheric function. Now, so clinically, it was very obvious. He's got one or maybe two seizure types, but predominantly one seizure type, which clearly is lateralized to the left hemisphere. That's quite obvious. Focal seizures with impaired awareness is definitely not coming from the temporal lobe with this kind of this thing. So we were thinking whether it's a frontoparietal networks. I would welcome any points at this point, just based on the clinical. Any comments from our August audience? Or should I proceed because of lack of time?
Is anybody commenting?
Sir, Dinesh, as you already said, it's a left post-central spreading on to central, pre-central, and onto the frontal. From whatever you described, that is the semiology.
Beautiful, sir.
I don't think there is anything more to say.
Anything more? Yeah. So post-central going to pre-central. That's that's what we also thought. And exactly, sir. That's very nice. So we'll come to the complexity of this.
Natarajan,
sir,
you have to not only that, you have to say that this has been going on for the past maybe a quarter of a century in him.
Yes, sir.
And persistent.
Yes,
no
sir.
change.
Yes, sir.
Very, very pertinent point, sir. That means the network is very limited. It has not
it has not
expanded.
spread. It has not spread. It has not worked out. I mean, this happens only in one or two conditions. Excuse me.
Yes, sir. Yes, sir.
Cortical, it is as described in all journals, left hemispherical precentral cortical dysplasia.
Yes, sir. Frontal, more frontal. Yes.
Okay, take a little bit of frontal.
Yes, sir. So the telemetry, which I did, in 2009, that's long back. So we have a very long follow-up on this gentleman. So if you look at the interictal epileptiform discharges, you can see that it's actually seen in the midline parietal, PZ and CZ. So parieto-central, obviously it's extending to the left parietal and central. So C3, P3, P3, C3. And less in the frontal actually. So it's basically parieto-central and it is in the midline and the left. So that is what.
This is a bipolar EEG or
no, this is a common average, sir.
Oh, okay.
Common
that
average.
is monopolar.
Monopolar, yes.
Monopolar.
It's monopolar. So you get the absolute values.
The location you will get it.
Yeah, the location is very clear in this. So yes, sir, that's right. So I will show only limited. So that's very clear that it is the same field. Now the ictal we recorded, and you can see the ictal. I'll show the video. Yeah, you can see that. You see what happened? Yeah, that's it. So he gets that, that arm getting stiffened and raised and the head going slightly to the left. And the left arm is, and then there is a clonic. See, there's a clonic only towards the end. And there's a figure of 4.
Figure of 4. Yeah.
And it goes on like that. And, it's bilateral convulsive. That's because we had slightly reduced this medicine. So just to bring on the seizures. So the point here is that at the beginning of the seizure, I will just stop at that. That is the point. You see the arm getting stiffened and elevated, and the head immediately turns slightly to the left not in a very forced manner. And that's the next point. And you can see that that's the raised arm, and that's the figure of 4. And now bilateral convulsive, very clear. So, okay, so I'm going to go to the next slide. Oh, sorry, next slide. Yeah. So the point here is that obviously, you will not be able to see much. You see that this is arising from sleep because the background, you can see that it's in sleep. And then you have these, burst of fast activity, which is seen bilaterally, but predominantly mainly in the parietal region. And then you see that, there's a very much muscle activity and very difficult to know where exactly it's coming from. So that's what it is. So now after a gap of 11 years, we did another video telemetry, and just to show that, these are basically the interictal discharges are almost the same. You can see that it's a run of discharges in the parietal region, P3 and C3, P3, C3, and the midline, P3, C3, midline, very nice runs, absolute runs of them, and nothing much in the frontal actually. It's predominantly in the parietal and the central. So the EEG has remained practically static over the last 10 years. Now let us see the ictus. This is coming from sleep. Let's see. Oh yeah, that's an asymmetric tonic spasm seizure. You can see that the right arm is not moving. The left arm, that's arising from sleep. So over 10 years, that's a minor one. That's a minor one. And the next one I will show very brief ones.
My video is missing.
So that's another one, and is a little confused. Again, the same thing. The thing is that he gets the same thing in the arm, and the right arm is always in action. And the last one is probably a little more elaborate. You can see that very nicely. Yeah, the arm is a bit stiff there. Right arm, the left arm is free, and it is kind of automatic. And you can see that the right arm is tonic. So these are the seizure types. Always begins as a tingling and a tightness in the right arm. And so the ictal EEG, you can see that, after this burst of a kind of a diphasic large, what is called a DC shift, and you can see this very fast activity which is seen, but it is all over the place. It's very diffuse, very difficult to lateralize it. So the lateralized features were only on the EEG interictal, but not on the ictal, which is usually the case in all these tough, difficult ones. So that's why I call it the Statue of Liberty side. When the arm is elevated, you can see that very nice. And that's a kind of a feature that sometimes you see, and it's a nice exposition of that. So the formulation here that we had was, this is a drug-resistant focal epilepsy syndrome, which is a left hemispheric extratemporal. Now there is a combination of both sensory, which is tingling, and motor, which is tightening and raising the arm, but no clonic at the beginning of the seizure. So it's a focal tonic seizure, no Jacksonian march, no epilepsia partialis continua or fixed weakness, no sensory impairment. Hence, therefore, based on these findings, we can be sure that this is unlikely to arise from the primary motor or the sensory cortex. That's the first thing. So we have excluded those two particular regions. But when you have these elementary motor seizure, this can arise from different areas. It could come from the premotor, it could come from the supplementary sensory motor area, it could come from the precuneus, it could come from the mid-cingulate, it could come from the insula. So these are the regions that have an integration of sensory and motor, and that's very important to understand. And that's what it is. So it need not come from it could come from anywhere from behind, as Professor Zahir beautifully, and as Professor Natarajan very nicely showed, it could come from behind and come forward. Professor Zahir very nicely localized it very well. So let us see what has happened to this particular gentleman. Now the MRI in 2009 we had done, and that was reported as normal. In 2016, an MRI was done in Nimans with the epilepsy protocol. Again, no abnormality. You can see that. So this is a MR negative extratemporal epilepsy syndrome, focal. They did a PET MR fusion in 2018 in Nimans, and they found that there was no discrete lesion. And what they found was there was a mild left frontoparietal atrophy, and the whole region, they felt there was a moderate decrease in metabolism. Again, we already clinically know that it's frontoparietal, but nothing more than that could be further done. And they again, it was the MEG was done. And you can see that the MEG cluster is predominantly posterior, and it seems to be behind the sensory, behind the central sulcus. That's quite posterior there. So left posterior frontal cluster dipole, left parietal region. So this is the central sulcus, and it's clearly behind the central sulcus. So it's that's the hand knob, and it's behind. So again,
Dr. Nayak, how was the dipole pointing?
The dipole was pointing forward, sir.
Forward.
Most of the dipoles are pointing forward, so it's somewhere from behind to front. That's what they mentioned. So it would come from somewhere just behind the central sulcus and then point more towards the front. And that's the thing. But there was a fairly tight cluster, as you can see here. But it all seemed to come from behind. That's the point. And see, that's the central sulcus there. Everything is behind. Now that goes well with our EEG. And that goes well with our clinical, which is, there's got a tingling sensation. So among all the structures that we have noted, these are the ones. Now, the point is, so this boy was quite desperate now, and he was willing for further analysis and evaluation. And lo and behold, what we did was, we got a 3T MR done this time. And there was a suspicious area. Now that's the central sulcus there, the hand knob. And just in front of the central sulcus, that's the precentral sulcus and the premotor area. We thought that there was a slight hyperintensity in the depth of that sulcus. Very subtle, very subtle. That's the point. Very subtle, but we're not sure. But our MEG cluster was behind. Our EEG cluster also was behind. And so therefore, we did not know whether this is just a silent spectator there, or in what way is it participating in the epileptogenic network and process. No other abnormality was there as opposed. So, and then we decided, based on that, okay, let's do a PET and see. And okay, so on a T, that was seen only on flare, because on a T1, very difficult. I mean, it's impossible to make out anything abnormal. So that's the reason why it has been missed many times. But the PET showed a very nice, discrete hypometabolism, which kind of corresponded to that particular region. Very nice. You can see that there's a particular hole in the cortex there. There's no metabolism at all there. And this we did based on, we found that, okay, maybe the MR is showing something there. So let us look at it more carefully. We got it done. So it's the value of repeating a test if you are based on a new information. And the only way to find out is to, study the network. That's the only way you can actually understand whether that is, these are the things. So, you need to study the network. So what we decided was that we need to, the so-called lesion. So we had an electrode in front of that. So that's what we call as the prefrontal there. Then you put 3 into the lesion, the anterior arm, inferior arm, and the posterior arm of the lesion. And then the inferior frontal gyrus, that's the reason, because, he used to sometimes get speech arrest. So we wanted to find that out. Progressively from front to back, the motor cortex, the sensory cortex, the precuneus, midcingulate, and the 2 insulas, the anterior insula and the posterior insula. So we did that. And these are the electrodes. And I'll just show you see that that's the same seizure type. Yeah, that's again the same seizure type. The seizure type remains the same. So he raises his arm and all that. So I'm not going to go too much into that at the moment. But where we found was that there was this lesion posterior, which is very close to the motor cortex. It's just abutting the motor cortex. That showed a lot of spiking there. And that was a bit disconcerting because it's very close to the motor cortex. And that's the ictal onset, and very nice. It involves only the posterior and the anterior limbs of that so-called lesion. It's also involving the motor cortex. And all the other regions, it's only a spread. That's it. And then later on, it involves the sensory cortex. You see that it doesn't, the sensory and the motor cortex are not involved at the beginning. It is involved subsequently. And this is the same thing. See the lesion posterior, very nicely seen. And that's a very nice fast activity, which is then spreading to the lesion anterior. And then it is going to the inferior frontal gyrus and all that. So we mapped out, and once we mapped out, we thought that the lesion posterior electrode is the one, and the contacts 3 and 4 of that. So then we wanted to see whether that is the region. And so we put a small current, and you can see that when you put a small current, yeah, the same tightening of the arm, and that's the same. So we could evoke the same seizure from that particular electrode, which is actually lying in the depth of that sulcus. And we got the same, you see that 2 milliamps, and that's the thing. And that provokes not only the clinical seizure, but the electrical signature also is absolutely the same. So not only the clinical, but the electrical signature is the same. So we were pretty sure that the lesion is responsible for the seizure. Now, when you stimulate the sensory cortex, you see his description.
The other day, 3-4 years ago, we passed by. I think we were standing outside the gate. The day Stalin was passing by.
Is it? That's a primary. See, that is a physiological symptom. When you stimulate the sensory cortex there, you get, it's not a seizure. He gets the function. 7-8. Sensory cortex. Yeah, so that's what it is. Now, when you stimulate the deepest contact of the insula, that's the deepest contact there. You just see what happens. That's posterior insula 1 and 2. Very small current. That's absolute classical of a insular seizure. I mean, this is not a seizure, this is a function. And why people, whenever somebody complains of a cough and somebody holding the throat, and that is because the insula is getting involved. And this is just to show the physiological functioning of the insula, and those deepest contacts of the insula produces that. So finally, we found that the seizure is coming from the premotor area, not from the postcentral gyrus. Premotor, depth of sulcus, but unfortunately, it is just abutting the motor cortex. So that is why we are on a razor's edge. Now you try to remove that area, you may develop a hand weakness, which can be permanent, and that can be a very tough exercise. So there's we are on a razor's edge at that point in time. And so therefore we have to now map on the table. And when you stimulate the area, yeah, that's all. So we mapped the motor cortex on the table, and we mapped out the entire, see that this is the central sulcus. Yeah.
Where wrist contraction came. And adjacent to that here is the thumb area.
Thumb area we could make out which is there.
Contraction was elicited at 2-3 milliamps. So the lesion is just anterior to the vein. Lesion is anterior to this vein, probably this. Maybe the inferior border, we are not sure. This is here in front of the sulcus. What you see in the scan, in front of this depth of the sulcus is the lesion here.
Yeah.
There's the hand knob, very nicely displayed.
So that is where it is. So the point is that you see, this is the underneath this sulcus is where this problem is, and it's just next to the motor cortex. And we have to work under the depth, because there's no point in removing only the surface, because the seizure is going to come only from the depth of the sulcus. And one should not damage the white matter tract just below that. So that's the point is that, and we could achieve that just removing only that particular sulcus. And you can see that the opening on the top is a small one, but we could scoop out that particular region. And that's the motor cortex, which is preserved. basically. And as expected, the pathology came as a type 2B, which is a focal cortical with a Taylor type, left frontal focal cortical dysplasia. And you see that the thing is that he's become completely seizure free. If you look at the literature, that the outcome of the bottom of sulcus dysplasia is very good, provided you remove the whole thing. And here, so the thing that the learning points that I've learned and is to be dogged in your pursuit. It took 10 years for us to try and convince him that, okay, we can do something for him. The investigations can be misleading sometimes because, you could see that initially the MRIs were normal. The EEG showed more posterior. The MEG also showed more posterior. Our analysis also showed that, the sensory and the motor means that it's coming from behind. So, but if you have a good electroclinical network hypothesis, and if you use a judicious use of stereo EEGs, I think it's beneficial in many of these cases. So thank you very much. And I would pay my pranams to my teacher who actually taught me everything about intracranial EEG, Professor Colin Binney. I spent 3 years with him and he almost handheld me and taught me everything about intracranial. And of course, it's teamwork. Thank you very much for your attention.
Thank you, Dr. Dinesh.
I'll stop sharing the screen, sir.
Yeah.
Yes, sir.
Any comments?
Any comments? I would be happy to. I hope it was
Wonderful, Dr. Dinesh.
Thank you, sir.
It's a proud moment, Dinesh, to see that such work is being done in Chennai. I mean, it's absolutely thrilling to say. Could you say something about this bottom of sulcus dysplasias? I think Vijayan had highlighted that this is what it is going to be. He projected it earlier.
Professor Zahir, sir, said it is going to be pre-central. He just told that. It's remarkable how he said that this is a bottom of sulcus. I mean, he said it's going to be.
No, my remarks were, hello.
And he said it's going to be pre-central. Yes, sir.
He's coming live.
Hello, can you hear me?
Yes, sir.
Yeah, I said, two things I said based on two facts. One, his history of focal epilepsy has been, the seizure type has been the same for the quarter of a century. It hasn't changed. Same thing happens every time. Second thing is this thing. In our good old days, I think it's proven now that the arm swing up with the turning of the head is probably a supplementary motor area phenomenon.
Yes.
And third, with this duration, I can't think of anything else but a cortical motor.
Yeah. Yes, sir. It's very, very nice. And these FCDs are, these bottom of sulcus dysplasias especially, they can be missed on a routine MRI.
Yes.
And in certain and the problem is that sometimes only one of the sequences will show. It may either be a T1 sometimes it may be a T2, sometimes it may be a flare only. So that is the problem. So, and then it's better to acquire, a 3D imaging. That is the zero slice cuts. That means, the interslice difference should be not more than 0.7 millimeters. Then what will happen is you get almost a continuous sequencing. And then you can slice at different levels and you can then pick it up. Otherwise, a thick slice can miss the bottom of sulcus completely. So these are the learning points. Again, I must emphasize that it's only the clinical clue that comes to the picture. That's the point. The clinical clue and which are the anatomical substrates that are responsible for that particular clinical picture. Ultimately, it's clinical. All our investigations are going to be supportive. So if you don't have a good clinical understanding of the network, I think it's going to be a wild goose chase. And we'll do more and more investigations. We get trapped under the investigation. And that is the thing. That's what my highlight is.
Can I further distill your remarks? What is important is history, history, history.
Yes, sir. Correct. Sir.
And second thing, Walter Binney, Dr. G.A. will remember, was with us in one of the neurophysiology symposia, if you recall.
Yes, sir. Yes, sir. Yes, sir.
When you are talking about cortical dysplasias, it is good to pay a good amount of respect to Fred Anderman from Montreal Neurological Institute.
Yes, sir. Yes.
Who
The
was
pioneer.
the pioneer in cortical dysplasias.
Yes, sir. He's the one who. Yes, sir.
Dinesh, sir, one question for you, sir, if I can ask.
Yeah.
Yes, sir. Just, sir, what is your comment? What is your comment on the point that the MEG clustering was much more posterior from the actual dysplasias? Because MEG is supposed to, take pathology and basal
No,
depth.
that is the mistake that people make. People depend a lot on MEG. MEG just follows the EEG. It gives another picture. That's it. So the EEG, if you see a lot of spikes on EEG, you're going to see the same thing on the MEG. Where EEG does not work, the MEG may help you to pick up because the MEG is better for because that's it. That's all it does. So you cannot depend on MEG alone.
Because it was BOSD, sir, still MEG missed it completely.
Yeah, that's true. Yeah, it can. Yeah, that's true. It should have picked it up better, but no. Sometimes it happens. So never get trapped never become a slave to investigation. Thank you. Thank you very much, sir.
You're welcome.
Thank you. Thank you, Dr. Dinesh. Can we now invite Dr. Viswanathan? Dr. Viswanathan?
Whole masala, pura masala. Aloo tomato bhaji. Whole masala. Pura masala. Masala ही खाना है. पूरा ही डाल है.
Hello, sir. Thank you for the opportunity. It's going to be a difficult task. Can you hear me, sir?
Yeah.
Yeah, okay. It's going to be a difficult task to follow such wonderful presentations. I think mine would be a much more mundane presentation, but anyway, I will try to make it as interesting as possible. I'm going to discuss about calcifying leukoencephalopathy in children and the lessons learned and how we made we present basically 8 patients, 3 sibling pairs. Of course, I have to say this was a presentation made a few years ago, but then it still holds good. And that's why I thought it'll be discussing this cases. So 8 patients, 3 sibling pairs and 5 families. Similar clinical picture, early onset encephalopathy, spasticity stroke dystonia, microcephaly, seizures, and consanguinity. The main differential diagnostic labels we had was spastic cerebral palsy, congenital CMA infection, and post-meningitic sequelae. And these were the differential diagnoses that different diagnoses that these children had. The clinching neuroimaging findings with what led to the diagnosis eventually. So the index patient was a firstborn to a 25-year-old primary gravida, a female baby, 3rd degree consanguineous marriage. At 20 weeks of gestation, the mother had high resistance flow in the right uterine artery, echogenic bowel. At 24 weeks, the femoral length was less than the 5th centile, and the head circumference were both less than the 5th centile. So the amniotic fluid PCR for CMV, rubella, toxoplasma were all negative. The triple screen, which we do for Down syndrome, was negative. And the
Viswanathan,
yes, sir.
We are not able to see. We are not able to see your slides. You are not sharing your slides.
Oh, sorry, sir. Should I start all over again, sir?
No. You continue. Continue from where you left.
I'm sorry, sir. Let me try to share it. My apologies, sir. Sorry. Now now you can see it, sir?
Yes, please.
Yeah, I'm sorry, sir. I just didn't realize that. So the Antenatal, as I said, had a high resistance flow in the right uterine artery and the echogenic bowel. This is for the mother. At 24 weeks, the femoral length and the head circumference were well below the 50th centile. The mother did have a lot of tests, including CMV, Toxoplasma, Rubella. They were all negative, and triple staining was negative. The baby was born at term LSCS, fetal distress, had a birth weight of 2 kilos, had thick meconium stained liquor, head circumference, weight, and the length were below the normal centiles, and discharged after 3 weeks. At 1 month of age, the baby was very irritable, had jitteriness, poor feeding, roving eye movements, and hepatosplenomegaly. The blood counts were normal. The CRP was negative. Electrolytes, calcium, phosphorus were all normal. The CSF was normal. All cultures sterile. Ammonia, lactate, pyruvate were all normal. And the CT brain showed multiple, as you can see.
Slides are not coming. Slides are not coming.
They're not coming, sir?
Yeah, they're coming now. I can see them.
We are seeing. Them.
Sorry, sir.
Very well. It's only coming. It's coming only now.
Not very clear, Vishwam.
I see, sir. I'm sorry. I'm not sure why, what's happening, but should I do it again, sir? Or
No. I can see the CT scans.
Okay, sir. These are had multiple calcifications on the CT. Spotty, around the periventricular region and the frontal region, etc. The torch ELISA was negative, and the urine CMV PCR was negative. The eye examination showed no chorioretinitis. Thorough workup for intrauterine infections were negative and labeled as possible intrauterine CMV infection and had received ganciclovir elsewhere. There were frequent admissions for seizures and fever. The sepsis workup was negative and treated as possible or probable sepsis. And this is the child who had these, at 4 months of age, had refractory seizures, tremors, irritability, roving eye movements, hepatosplenomegaly, had no social smile or head control, not following light, was already on multiple anticonvulsants for this. He died at 6 months of age, admitted to PICU, had aspiration pneumonia, refractory seizures, developed necrotizing enterocolitis, and had septic shock. This was the first patient. The second patient was a firstborn male, 3rd-degree consanguinity, uneventful antenatal and natal period. At 37 days of life, the baby also had fever and irritability with poor feeding. Electrolytes, cell counts were normal. The CRP was negative. Electrolytes was essentially normal, but the CSF showed 48 cells with 98% lymphocytes. And the protein was marginally elevated and glucose was not so low, essentially normal. All cultures were sterile. Ultrasound cranium showed echogenic thalamostriate vessels, torch ELISA, and the CMV, urine CMV were negative. I showed no chorioretinitis, but this time treated as meningitis for this child. On follow-up, the child had global developmental delays, seizures, spasticity, dystonia, and microcephaly, this time labeled as post-meningitic sequelae. This is the baby. The younger sibling of the same patient, of the second child, at 5 months of age, had no head control. And the CT brain also showed multiple calcifications, both in the basal ganglia as well as in the periventricular region, posteriorly as well, but predominantly in the basal ganglia, a little bit of spot in the frontal region as well. MRI brain showed pretty much a loss of volume in the brain, all over the brain, frontal, parietal, predominantly. This is another patient, 3 months female seizures not attained, had seizures not attained head control or social smile, and CT brain showed calcification predominantly in the basal ganglia. On review of the elder sibling, the 6.5-year-old male had spastic quadriparesis, seizures, cerebral palsy was the diagnosis. At 5 months of age, CT showed calcifications in the brain, torch workup was negative. And this was a MRI, again showed a lot of loss of volume with some tachygyria, some neuronal migration, polymicrogyria with some neuronal migration disorders. But a loss of volume all over, or whether it is not developed properly also is the other question. Here, there is absolutely no gyre or sulci. So similar, we have a family of 3 families, all with similar phenotype, consanguinity history, sibling recurrence, leukoencephalopathy with intracranial calcification. Can I stop here and maybe request for some comments or opinions, please? Or should I continue, sir? Hello, sir.
Are there any comments?
Sir, some pediatric neurologists, if they are there, they can comment, sir.
It's just, I mean, what I wanted to highlight basically was this was all, similar phenotype, and there was history of consanguinity in all this with a sibling recurrence with intracranial calcifications and a leukoencephalopathy, and with different diagnoses. One is cerebral palsy, one is, post-meningitic sequelae, etc. Anyway, calcifying leukoencephalopathy in children can have lots of differential diagnoses. And commonest, of course, is your congenital CMV, toxoplasma, HIV, etc. Aicardi-Gouthier syndrome. I will come to this later. Band-like calcification with simplified gyration and polymicrogyria, Cockayne syndrome. Both in Krabbe's and Alexander's leukodystrophy, although the predominant involvement is white matter, you can get calcifications in the brain. SLE, hypoparathyroidism, organic acidemia. All these can cause calcifications in the brain. The congenital CMV, toxoplasma, rubella, and HIV were all negative in these children. Cerebroretinal microangiopathy with calcification and cyst is another condition. That is what we were talking about as CRMAC with cystic changes. That again was negative in these children. Band-like calcification with simplified gyral or polymicrogyria. This is a kind of band-like calcification that you tend to get. And these children did not have that. Cockayne syndrome is a completely different condition. I won't go into it in detail, but you do get a lot of skin involvement as well, ichthyosis, along with calcification in the brain. There are certain COL4A1 mutations, which you get calcifications. Usually they are very much in the ventricle or very much close to the periventricular region. You can get calcifications. You can get it in Krabbe's disease, which is basically a white matter disorder, which occurs within the first year of life. And they tend to progressively become very irritable, and they die within the first year or before 18 months of age. Alexander's disease, they have big heads, white matter disease, and calcification rarely can occur in these children. Hypoparathyroidism has multiple features. They can occur at any age, and they can be associated with calcification in the brain. Organic acidemia is very rarely, they occur quite early on in life, very rarely can be associated with the calcifications in the brain. So in our patient, it looks, all these children had Aicardi-Gouthier syndrome. They all suffered from Aicardi-Gouthier syndrome. This was a misdiagnosis, and a lot of other diagnosis was made in these children. The clinical phenotype was it can be very much like post-meningitis sequelae, but the most important thing is the pattern of calcifications in the white matter changes. It's also called a pseudo-torch syndrome. Microcephaly with intracranial calcification is the main feature in all these conditions. Our index case had TREX1 gene mutation. Sibling had RNase mutation. And the sibling 2 had RNase H2C mutation. All these are confirmed cases. And unfortunately, prenatal diagnosis or carrier testing was not done in the next case, and neither was prenatal diagnosis. And therefore, they ended up having more children with a similar condition. These are the very similar patients, 6 and 7 of sibling 3. So the calcifications were predominantly in the basal ganglia, quite large calcifications. They can be in the cerebellar hemispheres as well. This was another patient, with patient 8 with multiple basal ganglia calcifications and calcifications frontally, as well as with the extensive loss of volume in the brain. So in Aicardi-Goutieres syndrome, it was described in 1984 in 8 children and 5 families, published in the Annals of Neurology in 1984. It's an old condition, but we tend to forget it. Early onset progressive encephalopathy, basal ganglia calcification, white matter abnormalities, and interestingly, they all tend to present with CSF lymphocytosis. And that's what happened in the first case. That's why the patient was diagnosed as having meningitis. CSF had showed lymphocytosis, but invariably the cultures are negative, and negative serology for common CMV TORCH and the Toxoplasma CMV infections, usually negative serology they have. Sibling recurrences affected families. Prenatal diagnosis very much possible, and parental consanguinity is one of the main common causes. They all have raised alpha interferon in the CSF. Absence of demonstrable infections is the main thing that we need to think about. No demonstrable viral etiology. Herpes encephalitis, HIV, mumps, enterovirus, varicella, congenital rubella is all negative. There is a high titer of intrathecal synthesis of CSF interferon alpha. And what triggers is there are a lot of theories behind it. There's TREX1 mutation is the commonest, DNA endonucleases. Mutations in the ribonuclease H2 subunits are also well known. So defective nuclease causes accumulation of endogenous nucleic acids, provokes type 1 interferon response, activation of neurotoxic lymphocytes, and inhibition of angiogenesis. So congenital virus infection and Aicardi-Goutieres syndrome, both of them produce IFN alpha synthesis. And that's why you tend to get CSF lymphocytic lymphocytes increased. So CSF lymphocytosis, IFN alpha, all this is a typical feature of Aicardi-Goutieres syndrome. Genotype, most cases are autosomal recessive. Rare cases, you can get autosomal dominant TREX1 mutations. A lot of different mutations have been described for Aicardi-Goutieres syndrome. Early onset, most severe neonatal form is a TREX1, which is autosomal dominant. All the others are usually autosomal recessive. The phenotype spectrum, not yet fully understood. There is a huge number of phenotypic variations. At the age of onset in our patients, usually within the first year of life, usually around 4 months of age. Peripheral spasticity, dystonia, truncal hypotonia, poor head control, microcephaly, and seizures is common in all these children. Usually hearing is normal and vision normal, or cortical blindness may be there predominantly due to refractory seizures. The clinical, in our patients, most of them had spasticity, microcephaly, dystonia, eye movement abnormality, and none of them had chilblain-like lesions. CSF findings tends to fall with age. CSF neopterin is a good biomarker. The classical spot-like calcifications, what you tend to get. Rock calcification cerebellar hemispheres is what you tend to get posteriorly. Pontine calcifications are not uncommon. Periventricular linear calcifications, subtle cortical calcifications in the depth of sulcus, subtle basal ganglia calcifications, the white matter calcification. So you can get different types of calcifications for the same disease. And that's what makes it very difficult to make a diagnosis. The difficulty also is that the CT plus MRI sometimes yields better yield rather than just doing an MRI or just doing a CT alone. MRI changes, you tend to get the white matter changes, both prominent in the frontal as well as in the occipital regions, usually in the periventricular region. Seizure control, diet, feeding methods, chest physiotherapy, clinical course stabilization. Many of them develop glaucoma if they live long enough, scoliosis, IDDM, and hypothyroidism. Mortality in our patients, many of them, I mean, out of the 5, 3 died, 2 survived, but they also died more recently. Prenatal diagnosis is possible. The future is newer therapeutic strategies, including interruption of the NA binding, interruption of NA signaling, interruption of downstream immune pathways. Whether it's an autoimmune disorder is something Professor Aikadi himself wondered, but we still don't know. But the lessons learned is that anybody with a calcification does not suffer from just straightforward congenital CMV or toxoplasma or rubella. And consider genetic diagnosis as a possibility, particularly when you have a negative serology for CMV, toxoplasma, and rubella. And consider that the possibility of recurrence is there in the next pregnancy, and this can be prevented if suspected early, often misdiagnosed and mislabeled, counseling of a falsely low risk of recurrence, and calcification not always visualized on MRI. So consider MRI with CT if necessary. Let us think of AGS with phenotype, intracranial calcification, leukoencephalopathy, absence of definitive evidence of infection, consanguinity. Molecular diagnosis is necessary. I'd like to thank Professor Yannick Crow, who helped us with the molecular diagnosis a few years ago, and of course, all of the consultants who were responsible for sharing their cases also. Thank you very much, sir. I would invite any.
Thank you, Dr.
Thank you, sir.
Dr. Padma here, sir. Can I say something,
please.
sir?
Yeah, please.
Yes, sir. So definitely I know some of these children at least, but recently I had one child who actually had a CMV PCR positive, urine and blood copies also, and then turned out to be an intracranial calcification with a heart disease, with retinitis, something called an Adams-Oliver syndrome. So it is very, very difficult how far to investigate these children with intracranial calcifications. Like if you definitely have no evidence of intrauterine infections, we are definitely going to evaluate. But this particular child whom I'm saying had a urinary CMV PCR positive and blood CMV PCR also positive, and yet turned out to have a syndrome called as an Adams-Oliver syndrome, which is an intracranial calcification. So I don't know, genetics is becoming more and more difficult now. The more we investigate, the more we are getting. I don't know.
Absolutely, Padma. And I think, thank you very much. You were the one who made these slides for me years ago. And I really appreciate, and I just thought I'll share it in this medium because there were so many great knowledgeable people here, and I really
it was lovely, sir, lovely working with you.
Lovely, yeah. And I think you're absolutely right. I think the more we have genetics, the more confusing it has become. It's like your, Professor, what's his name, about CMT, he was saying it's confusion and chaos rather than anything else. I think so. Finally, I would say it is clinical. If there is any suspicion of consanguinity and you think there is a possibility, there are so many of these cases that we come up with the VOU as a variant of unknown significance, where I think if you're not clinically sure, ignore that and go with your clinical instinct rather than just go with it. Thank you, Padma, for pointing it out.
Thank you.
Vishwanathan, can I ask you something?
Yes, sir, please. Sir.
No, I just want to know what is the course and outcome of these children?
Most of them actually remain severely disabled, and many of them have severe oromotor dysfunction and severe dystonia, and because of which they end up aspirating unless we go ahead with the gastrostomy and fundoplication. And in our country, it's so difficult to convince people or convince parents about consideration of gastrostomy fundoplication, although we have been succeeding. And actually, we recently published a paper on the importance of gastrostomy and fundoplication in children with cerebral palsy. Many of them survive if we can do all that. But again, the quality of life is very poor, sir.
Thank you. Thank you.
Just if I may add, sir. Recently,
Yes.
there has been some updates that some people are trying immunomodulatory therapies for some of the Sekari gluteus, including the tocilizumab and steroids. So the more we identify, probably in the near future, some treatment options might come. I don't know.
That's true, Padma. But the only problem is, I think we are trying to treat the condition after the cat is born. I mean, like,
Cat is, yes, after everything is out. Yeah.
Oh, yeah, and therefore we're not going to achieve much. If we can treat the condition in utero, then it is
Probably it might be better.
Yeah, if we are going to treat it after the child is out and has got severe dystonia, and you diagnose it at 6 months or 8 months of age, then there is not much of a point, and all you're going to do is prolong the agony for the family. But if you can make a good prenatal diagnosis, a genetic diagnosis, then I think you can actually prevent more children being born in the from dumb and in the extended family if there is consanguinity. So that is the most important.
Yeah, sure.
Jonathan.
Yes, sir.
I'm Dr. Meganda.
Yes, sir.
Excellent presentation, and it was fantastic.
Thank you, sir.
Knowledge you gave us. Of course, we have seen several cases like this, and we were at a loss. We were, of course, it has given a lesson that in a case of intracranial calcification in a newborn and an infant, we have to think of other conditions beyond TORCH also, especially in siblings. When the siblings, we don't see TORCH infection in siblings usually. The second child, when the second child, third child is affected, we are dealing with some other genetic disorder.
Absolutely.
And probably we have to go for, apart from TORCH titer, we have to go for CSF interferon and genetic study if necessary after your presentation. That's what I thought, that as you already pointed out, that going further in the treatment aspect may not help much for these children because most of them die under our nose. We will not be able to do anything much of it. But I still feel there is some other infective component is still playing, mainly because that the interferon does not come in. I think CSF interferon shows that some infection which is going on. What do you think about it?
Absolutely, sir. I think there must be something in the mother, some maternal infection that crosses the transplacental barrier and triggers off a CSF, some lymphocytic, trigger. There must be something, but I think we don't understand as much. And that is the need, I think, for all of us in pediatric neurology to come together, because unfortunately, we don't have a good forum for getting all these rare cases together and combining and putting all our knowledge and database, because we see more cases than the rest of the world. And that you brought a very important point, sir. Thank you, sir.
Thank you very much. Thank you.
Sir, if there is no other thing, I will stop sharing the screen, sir.
Oh, thank you, Dr. Viswanathan. Thank you very much.
Thank you, sir.
And, you can make arrangements to get all the pediatric neurologists under one platform and discuss all these difficult cases.
Thank you, sir.
So you have done it earlier. You have done it earlier.
Yes, yes.
Can we go on to the next?
Yes, sir.
May I invite Dr. Malcolm Jairaj.
Good morning, sir.
Doesn't need any introduction. Welcome, Jairaj. Welcome.
Good morning, sir. Good morning, respected senior professors, colleagues, and friends. At the outset, I thank Professor P.U. Velmurugan, sir, for giving me an opportunity to share this case. It's a case of where I had some difficulty in management, and still it's going on. Sir, am I visualized?
You are visualized, but your
Slides are not visible. My slides are visible somewhere?
No, your slides are not. Yes, Jayaraj, you are getting.
Yes, sir.
You are getting it. The slides are on.
Yes, sir. My slides are on, sir. I've shared the screen also. Are they visible, sir?
Yes, please go ahead.
I'm presenting a case of a 13-year-old girl who came with recurrent seizures since 3 years of age. She was a second born of non-consanguineous parentage with apparently normal birth and development, and there was no history of any antecedents. Her habitual seizures started at around 3 years of age. And the initial presentation was there was no aura, but there was a head-eye deviation to right side, followed by tonic posturing of the right upper limb, followed by tonic-clonic movements of the right upper limb, with a loss of consciousness lasting for around 5 to 10 minutes. The frequency of these episodes were around 1 to 2 per month. There was no clustering or nocturnal seizures. There's no history of generalized seizures or status epilepticus. No family history of seizures. Gradually, she started developing anger outbursts. Seizures were disabling, and because of recurrent seizures, she dropped out of school. She was started on oxcarbazepine and clobazam, and seizures were initially well controlled, only to recur later. And subsequently, so this went on from say around 3 years to around 7 years of age. And from around 7 to 10 years of age, the semiology changed and there was tonic posturing of the right lower limb lasting for around 30 seconds, followed by a few clonic jerks. And these used to occur several episodes per day. The mother also noticed a near continuous jerks of the right foot, which was initially noticed during sleep and later during wakefulness. Subsequently, sodium valproate and later lamotrigine were added, but seizures continued to recur, and gradually she developed a right foot drop. At this point, she was referred to us, and on evaluation, we found out that she was a right-handed person. There were no neurocutaneous markers. The language was normal, comprehension, fluency, repetition, naming, reading, writing were normal. The cranial nerve examination was normal. The palmar grasp was present, but the pincer grasp was weak. There was a right foot drop. The dorsiflexors were around 1/5 and plantar flexors were 3/5. The right ankle jerk was brisk and the right plantar extensor, but there is no cortical sensory loss. There's no evidence of ataxia or any other involuntary movements. So we came to a conclusion that it is probably an extratemporal complex partial seizures with EPCs with a functional deficit, the right foot, and probably they are left hemispheric in origin. So with this, we reviewed the E genes child, and we found that the spikes were predominantly over the T3, O1, and T5 or left posterior. Somewhere they have seen independently over the left anterior temporal and also over the midline. And during sleep, we found that the right hemisphere had very good sleep spindles, but the left hemisphere, they're not well formed. And there was a continuation of spikes over the left posterior head region.
Not audible.
Yeah, I mean, it's taking some time to load up this. And this was done, this was a record that we obtained. In the first recording, we found that there were multiple such discharges over the left posterior region.
Sorry, Malcolm. We don't see the slides.
Pardon, sir?
EG is not seen.
You have to reshare you have to go back and reshare it. Then only it will work.
Okay, sir. Is it being seen, sir?
Yes.
Yes. Yes.
So there were electrographic seizures which were seen over the left posterior head region. I'll just show you. They seem to be evolving over T3, T5, and T501. And we could see multiple such episodes in the first EEG that we recorded. I'm sorry, sir, my slides aren't moving. Just a moment. Okay. So are my slides visible, sir?
Oh.
Now, sir?
We only see a slide stating MRI brain. That's all.
Yeah, MRI brain picture is not visible.
Yes, now we see.
Yeah.
Yes.
So this was the first MRI done at the age of 7 years. And we noticed that there was some amount of perisylvian atrophy over the left hemisphere. And these are very low quality images. And we found that there was a subtle atrophy of the caudate on the left hemisphere. I hope it's visible, sir. And at 10 years of age, when she came to us, we did an MRI again. And we found that there was a T2 flare hyperintense signals over the left occipital region and also over the left temporal region. And we found that the caudate, the frontal horn atrophy was more pronounced, and there was a caudate atrophy of the left hemisphere. So coming to the diagnosis, we made a diagnosis of an extratemporal complex partial seizures with TPCs, with a functional deficit, with caudate atrophy, and with the T2 flare hyperintense signals, probable Rasmussen's encephalitis involving the left hemisphere. So an initial management strategy we followed was an IV methylprednisolone followed by oral steroids at around 1 mg per kg body weight. Methylprednisolone was given as pulses every month, and we followed up with a 1 milligram per kg body weight of prednisolone. But there was recurrence of seizures, and she developed neurosepsis. So we discontinued and we went back to immunoglobulin, and we gave immunoglobulin for around 4 cycles. There were reduction of seizures, an improvement in anger outbursts, but there was no major functional decline further. This was the EEG that we have done now, sir. So there is a behavioral change initially, followed by right facial and right upper limb jerks. There were also abdominal jerks in her. There was an obvious paucity that was noted in the right upper and lower limb following the seizure, which gradually recovered, but there was no speech arrest in her. So this was the onset of the seizure, and we found that there was a delta to theta rhythm which was evolving over the left posterior region in her. This is the latest MRI that we have done in her. This is at 13 years of age. So the first one I showed at 7, the second is at 10, and this one is at 13 years of age. And there is a gross left hemispheric atrophy. Just give me a moment, so my sides are not moving. And this is a coronal view showing the same left hemispheric atrophy with grossly dilated ventricles. And we proceeded with a functional MRI for her. The functional MRI was reported as a left cerebral hemispheric gliosis. The foot activation was still noted in the left paracentral lobule. The bilateral speech activations with more robust motor activations were noted on the right inferior frontal region. But the sensory speech was noted over the bilateral superior temporal gyri. This was the report that was given to us. So I just want to discuss two things. One is the natural course of the Rasmussens and take it in relation to my particular case. And what do we do next? So Rasmussen is, as we all know, is a focal seizure due to chronic localized encephalitis. It is infiltrated with T lymphocytes, microglia activation, microglial nodules, astrogliosis, and neuronal loss. The pathogenesis is twofold. Initially, it was thought humoral immunity played a major role, but now they say T cell immunity plays a much major role, and it's rather combined. And this is the European Consensus Statement of 2005. And according to the statement, our patient clearly fits in with the diagnosis of Rasmussen's with the uniform hemispheric slowing, and there is a unilateral seizure onset, and there is also unihemispheric focal atrophy, gray or white matter T2 signal, hyperintense signal, and there is a hyperintense
1 minute.
signal or
Malcolm, 1 minute.
atrophy.
Dr.
Yes.
Kanchana, can you mute your audio, please? Can you mute your phone? Dr. Kanchana, please mute your phone.
Muted.
Yes, Malcolm, you proceed. Sorry.
Yes. So, with regard to the phases of Rasmussen's, there are 3 distinct phases of Rasmussen, namely a prodromal phase, an acute phase, and a residual phase. Now, from Bean's article, we come to understand that the prodromal phase lasts anything between 0 to 8 years. The acute phase goes on for around 4 to 8 months, and the subsequent is the residual phase. Now, the characteristic features of Rasmussen are epilepsy, functional decline, and the atrophy of the brain. So, in the prodromal phase, all these are minimal. While in the acute phase, that would be very frequent seizures and the functional decline worsens. While in the residual phase, the seizures are present, which can be in the form of a drug refractory epilepsy, but the functional deficit has become stable and the atrophy becomes established. Now clubbing the MRI and the histopathological features with the functional features of the 3 phases, we find that the MRI also goes through stages, where stage 0 is no abnormality, stage 1 is there is a swelling of the cortex and the hyperintense signal. The stage 2, there is a hyperintense signal and a normal volume. Stage 3 is atrophy and a hyperintense signal, and stage 4 is atrophy and normal signal. Now, clubbing the imaging stages and histopathology with the clinical pathology, we see that in the prodromal phase, it is grade 1. The histopathology is not very much clear. The acute phase falls within the MRI stages 2 and 3. There is a decrease in T cells and reactive astrocytes. And finally, the stage 4 falls in the residual phase with the neuronal and astrocyte loss. The other way we look at Rasmussen's is there are two types of progression in Rasmussen's. One is a type 1 progression, the other is a type 2 progression. The type 1 progression has an earlier onset, a short prodrome, a more functional decline and atrophy, presence of dual pathologies, and hemispherectomy is the methodology of treatment that is offered. In type 2, the onset is much later, the prodrome is very long, the functional decline is less, there is no dual pathology, and whether we have to really treat with hemispherectomy is a major question. Now, and what are the modalities of treatment that we have for a patient with Rasmussen's are namely 4. One is an anti-epileptic drug, 2 is the epilepsy surgery, 3rd is a short-term high-intensity immunotherapy, and the 4th is a long-term immunotherapy. The first 3 are aimed at seizure control, while the long-term immunotherapy is aimed more at the prevention of structural and functional decline. Now, putting this all into our patient and seeing our patient has got a very long prodromal phase, and it follows a pattern of probably a Rasmussen encephalitis type 2, though the onset is much earlier. But our patient has got handicapping epilepsy, and the issue is, can we do a hemispherotomy in this patient, and what would be the deficits? The main issue is the language concerned, and as we saw in the ictus, there was a post-ictal motor deficit, and the functional MRI still shows the motor cortex is probably on the left hemisphere. So the treatment, what they are recommending is a long-term immunotherapy plus or minus 2 ADs, which we did try in this patient, but it has not yielded much benefit. The seizures are still continuing and quite disabling. So do we proceed with hemispherotomy or do we continue with immunomodulatory therapy? Now, I'll go to the next slide. In summary, this is an onset of illness before 6 years of age. There is a hemispheric atrophy in our child. There is a functional deficit, but we do not know whether it is stabilized as yet. There is a refractory seizure. There is a bihemispheric language, and also the motor cortex is appearing on the left hemisphere. Due to COVID considerations, they didn't want an invasive procedure for now. So what is planned? What do we do next? So with this in mind, I looked into a review of literature with regarding to long-term immunotherapy versus a hemispherotomy, and what are the pros and cons of both. This was one interesting paper from Granada, where they said the experience with immunomodulatory therapy in patients with Rasmussen's encephalitis, and they recommend immunomodulation to delay surgery, especially when the patient has got a late onset RE with a slower and milder course, when there is a dominant hemisphere involvement and there is a slow progression, when there is a suspected RE but neurological deficits have not occurred, in a case of a bilateral Rasmussen's, or whenever there is a severe compromise requiring optimization and stabilization before surgery. And these are the various modalities that they offer for an early onset and a late onset in long-term management. It's either oral prednisolone with boluses of methylprednisolone, or oral prednisolone with IVIG, or oral prednisolone with plasma exchange, which they say is for the long-term management. Now, coming to people who argue for hemispherotomy in a dominant hemispheres, the European consensus statement very clearly says the indications are in very severe intractable epilepsy, impending complications due to epilepsy, please proceed for a hemispherotomy. Whenever there is a severe stable aphasia, kindly do it. When the disease onset is prior to 4 years of age, when they say that the language shift would have occurred, you can proceed for a hemispherotomy. But what really happened to these children on a long-term basis, there were a few interesting articles where they followed these patients on long-term and regarding language recovery after left hemispherectomy in children. The initial they saw 5 patients where they said the receptive functions were comparable or surpassed pre-surgery performance. All the word repetition was intact 1 year after surgery. Naming remained impaired, and patient speech was largely limited to production of single words. So there was an expressive aphasia in these patients. Now, there is another interesting article from the John Hopkins where they said, why would you remove half a brain? What is the outcome of 58 children after hemispectomy? And they saw various etiologies, and one of them was Rasmussen's. They saw 27 such patients on a long-term follow-up of 6 years. And they evaluated in terms of a burden of illness scale, including seizures, motor dysfunction, and intellectual dysfunction. And they found that the burden of illness score was much less after surgery in patients with Rasmussen's, especially, and they make a very critical remark. And they said that 8 right-handed children underwent left hemispherectomy. The oldest was 12 and 13 years. Language redeveloped in all, more completely in children with shorter duration of illness. And they say that left hemisphere should not be a reason for delaying surgery. This is another article from almost the same group where they saw the cognitive outcome of hemispherectomy in 71 children. And they all say once again that the expressive aphasia is the most, the issue after surgery in all these patients. This was one of the another latest articles from the Japanese group where they evaluated immunomodulatory therapy versus surgery for Rasmussen's in early childhood. And this is the conclusion they are giving. With regard to seizure outcome, cognitive outcome, and motor outcome. They say with regard to seizure outcome, it is best with functional hemispherotomy. But to surprise, they say that steroids have done very well with regard to seizure outcome, cognitive outcome, and motor outcome. However, they have not spoken of what is the language issues in a dominant hemispherectomy. With regard to IVIG, they have given a dismal outlook, and they say neither the seizure outcome is very good nor the motor outcome is very good, but cognitive outcome is reasonable. The another kid of the block is tacrolimus, where they say it could be a steroid sparing agent, and they say the seizure outcome and cognitive outcome, though mild and moderate, the motor outcome is very good in such individuals. So coming back into our child again, a child with an onset of illness before 6 years of age, a hemispheric atrophy at this point of time, a functional decline with the right foot drop and a poor pincer grasp. We do not know whether functional decline has stabilized, especially with regards to the speech, with refractory seizures, with bihemispheric language on fMRI. The motor still, in the sense it is still showing activation over the left hemisphere. Of course, a WADA to be done. Do we proceed in this child for a long-term immunomodulatory therapy versus a hemispherotomy? Sir, I want to get the floor's opinion on this patient. Sir, am I audible? Hello?
Yeah, you are audible, you are audible, you are audible. In case you opt for a long-term immunomodulatory therapy, how long would it be?
That is one of the points that I reviewed, sir. They say that the max immunomodulatory therapy, the European consensus statement is saying is for around 2 to 3 years.
Sorry, 2
and
to
all
3?
these patients, 2 to 3 years.
2 to 3 years or
they
2
don't
to
have
3
data
decades?
to recommend. 2 to 3 years. And after that, they don't have data to recommend, sir. They don't have data to recommend.
Malcolm, you also showed that the immunomodulatory therapy, which is responsive for the seizures, is steroids.
Yes, sir.
So, is it high dose steroids, or what dose you would have to continue for 2 to 3 years?
They say it's oral steroids at around 1 mg per kg body weight.
Thank you. Thank you.
So, Dinesh sir.
Dinesh sir, you are called for your opinion.
Yes, sir, I'm there. Yes, sir. It's a very nice presentation by Malcolm on, can I, yeah, am I audible, sir?
Yes.
Yes.
Yeah. Very tough, isn't it? I mean, this dilemma all the time is there. And I think ultimately, I mean, in our population, I think very few only have really responded to or got arrested with just immunotherapy, various types. We have even, as you rightly put, steroids, then IVIG. Sometimes we have used rituximab. Sometimes we've used even up to cyclophosphamide, all kinds of things, just to, because the limb is relatively well preserved, but they have EPC, but rest of the time, or intermittent seizures, not EPC, intermittent seizures. Rest of the time, the limb is completely normal, and it's a dominant hemisphere. Limb is normal means then it's very difficult to, as you rightly put, to disconnect half a brain. Very tough. And sometimes it's restricted only to the perisylvian and the motor sensory cortex. Anterior to that is normal, posterior to that is normal, and you don't know what to do. But in your case, I think the entire hemisphere is involved, including the occipital lobe and the perisylvian cortex. And there's a lot of slowing in that region. That hemisphere is not working well. That's very clear, either electrophysiologically or clinically. And there is already a fixed deficit.
Yes.
Which means that there's a foot drop, which you said is there interictally also. And on top of it, the child is getting a lot of seizures. The most important thing here is that it started at the age of 6. So 6 is this way, that way, but 6 means that considerable amount of, sorry?
3 years.
3 years, 3 years, yes, 3 years. So, considerable amount of language function has already shifted to the other side. That is one of the important points, and very likely, that's what it looks like. But you have to prove it. And we have also done several like this, and we had to do a few with the left-sided. And sometimes you land up in an emergency surgery. That is the problem. When you keep waiting for, because you don't want to do the surgery, because you want to try out other things. And then sometimes they go into a focal status. And when it's involving the peri-oral, they'll start accumulating a lot of saliva and all that. They're not able to even swallow their own saliva. They're conscious, but they're not able to swallow their own saliva. They're not able to swallow, eat properly. And then I remember Dr. V. Vishwanathan had sent a child in 2012, and the same thing with a perioral, and he came on a Ryle's tube, and then it went on, and he stabilized till 2016. He was all right because he was left hemispheric, and he was 9 years old or 9-year-old at that time, left hemispheric, fully preserved hand and leg, but intermittently he'll get. Then in 2014. He went into a focal status only involving the face and hand and leg, which never stopped for 7 days and 8 days. And it had to be intubated because just to protect his airway. He's fully aware, conscious. We have no way of checking what has happened. 1 year back, we had done an fMRI, and that showed this exactly like what your picture is, exactly the same bilateral representation. Now, on a ventilator for 7 days, not able to come out, what do you do? I mean, we have tried everything for him. At that time, rituximab was not available, but we have given everything else. You're the same, like what, according to literature. Finally, we told the parents, we don't know whether his speech is going to go off. Second thing is, he is definitely going to be severely hemiplegic. See the 2 points. Because he was intact till then. Now we had to take, and then they were seeing this boy on the ventilator, we had to do it. 2014, we did an emergency hemispherotomy for this child just to save this from coming out, just to come out of the ventilator in the first place and stop the seizures. Today is 2021. he is seizure free. Okay, he's got a spastic hemiparesis, no doubt, but he's walking, he's doing everything else. He's attending school also. He's begun to write with his left hand, and his speech was initially a little non-fluent, and now it's become normal. So I think, and we did it at the age of 13, when most of the things are hardwired already, and his onset was at the age of 8 or 9. You see, so that means his language functions has already got stabilized. And this motor, unfortunately, even in early insult, is not going to shift to the other side. The language will shift, but not the motor and the sensory. That won't shift that easily. So I think you should, you're given a long course of with good faith, you're given every kind of immunotherapy. You've not tried rituximab. That's the only thing that I think probably you're not done. You can probably think about it. But I think I would, and it's a discussion between the patient and this thing, what is out of it. But here your decision is actually easier for many reasons. You see, the onset is 3 years. Language is bilateral. There's no doubt about it. And the opposite side will take over very quickly. And and the child has got a fixed deficit already. So you're not going to worsen it too much. What would go off would be the hand grip. That would go, that's for sure. But proximally and all that, we fairly all right. So your decision making is easier because you have already a fixed deficit and the onset has been earlier. This is my this thing. So your dilemma is less, but you would definitely go ahead and do a good immunotherapy again and see whether that works. But be prepared for a quick surgery.
Thank you.
That's my limited understanding of this condition.
Yeah, the thought for me also was to proceed for a hemispherotomy, sir. But the point was the bilateral activation of language on the and of course, that was the point. But after reviewing literature, I thought yes, we should proceed for, because on the long term, when they have seen this come.
You should. You stop the seizures, their quality of life will just dramatically improve. And the burden, you can actually stop all anti-seizure medicines. That's the biggest advantage. So the opposite hemisphere, which is fairly normal, will be, freed from the side effects of multiple anti-seizure medicines. And they'll start functioning better than before. So I think you should come out. Thank you.
Malcolm, when was the deficit has come? How long, how many years now?
Deficit is when they came to us, that's around 10 years of age. That is plantar, the dorsiflexors were weak.
Yeah, that's the same deficit which she has now. So last 4 years, her deficits are almost like stable.
With regard to foot drop, yes.
Yes. And I don't think fMRI can be the sole thing, because as sir rightly pointed out, there is a very high likelihood that the language would have shifted. So, sir, in these cases, sir, suppose in this particular case, if like when can an early surgery, like when the deficit came at the age of 10 years, can be offered? Are we better after 4 years, or will be the same at 10 years and now, sir? Is it the same?
I think it's a big dilemma. Offering a surgery without much deficit to start with, is not very easy.
So when the deficit came at 10 years, sir?
The deficit came at 10 years and at that point in time, you would have given a course of immunotherapy, and if it's not responding, then you would take a decision within about 6 months to 8 months.
Yes, that's what my point is, sir.
But but these are very difficult decisions.
I think these are more individualized, sir, to the patient.
Yeah, very, very highly individualized.
And there are parents, and we are going to tell them that she's going to have a language loss is something that any parent would take.
It is not easy. Decisions are never easy, and I think the parental aspirations and what they are, this thing is to be taken seriously into account. Some parents are very, very particular. I don't want a single deficit. Then you'll have to do immunotherapy. That's it.
So even rituximab, do you think is really definitely going to change?
I just wanted to make a comment on. Sorry, can I? I wanted to actually highlight a slide on rituximab. I went through rituximab and Rasmussen's, and a review of literature where they have given on a series of patients. And they also say that rituximab has got a very short-term benefit, and after a time,
that is what we are telling. That in our experience also, we have not found that rituximab a lot, the course of the disease a lot in our cases.
It's very disappointing.
It's only buying time, basically.
Can I come in, sir?
Yes.
Yeah, sure.
Vijayan. So I would just have an experience of treating single case, a 35-year-old female who in 1998 had focal seizures and then was started on anticonvulsants elsewhere. And then when she came to me, it's diagnosed actually as a demyelinating illness. Then when we started seeing the serial MRI, we saw that there was progressive atrophy of the left frontal parietotemporal regions. Then what we did was I gave her methylprednisolone for 5 days, initially not knowing what the diagnosis was. That made a subtle improvement and the seizure frequency decline. Then later on, I thought, why not? It could be a case of adult Rasmussen. So we did. When she came back, whenever I tapered the steroids, she got worse. She came back to us and she was intubated. I mean, she had a Ryle's tube. And as you said, sir, she was not able to swallow her own saliva, salivating excessively. We did a left middle frontal gyrus biopsy. And then we proved that it was Rasmussen, adult Rasmussen. In that case, I gave her rituximab. And well, there was a dramatic improvement, I should say. She is still under my follow-up. This is 10 years now. And of course, I have not given her further courses of rituximab, but I kept her on mycophenolate as immunotherapy, as continuation phase, maintenance phase immunotherapy. And she is still on mycophenolate and she comes regularly for follow-up. This is now 10 years. She's able to feed herself. She's able to walk with minimal support. She initially had almost a complete hemiplegia in 2011 when I first saw her. And then now she's able to actually walk with minimal support. She's able to communicate few words. Of course, she's not able to speak long sentences, but words and phrases, and she's able to swallow well. I've been putting her on only mycophenolate, placing her on mycophenolate, and she's okay, fairly doing well. I wouldn't say she's able to, she needs assistance for activities of daily living, but very minimal assistance.
Yeah, that's good. I mean, there are definitely outliers who behave, and it's a very diverse entity. It's not, I mean, that's an adult Rasmussen where the onset itself was long, and
Yes, sir.
I agree. I mean, we should do all these things, and as you rightly put, that we should give all the immunotherapy and see, you know, then sometimes you have some patients respond very well to certain drugs and they become all right or better. We also have some.
I'd like to add, sir, I've come down on the anticonvulsants.
Correct.
Almost nothing anticonvulsant. Only just she's taking levetiracetam 500 milligram twice daily, that much, not more than that. And she's not had a single seizure after that.
Correct. Good.
Sir, I know, can I just add Vishwanathan here? Just wanted to say that I find that if you can start immunotherapy early in these patients, they respond well. But I think quite a few years later, it doesn't seem to work as well, and that doesn't seem to make a big difference. So I think the earlier you consider Rasmussen's and start immunotherapy early, they respond much better and their long-term outlook is much better. That's my feeling. Because if you do see...
Good, very true, absolutely.
And that's what the literature also says.
Yeah.
The immunopathogenesis happens over the first few years.
Yes.
And your immunotherapy should target those first few years.
Yes.
But this patient came with a late referral, almost some 6-7 years after the onset. So
that's the point.
That's the issue.
One change of point which has happened, one paper which came last year actually, as Malcolm was pointing out earlier, the immunopathogenesis, which was earlier thought to be more of like B cell and then CD4, now the cytotoxic CD8 positive cells and adenosine based pathogenesis is also considered.
Yes.
So maybe in future we will have therapies which will have these adenosine based or CD8 positive cytotoxic cells mediated therapy.
Yes,
so
actually, I went through literature on that aspect also.
Yes.
And there are some reports regarding natalizumab in Rasmussen, and they say that natalizumab has got a very good effect on Rasmussen.
There was one paper last year which reviewed the whole article, and I think this has pointed out.
Well, I add one more point, sir. I am Dr. Meganda. We have had a few cases, and I go with Dr. Dinesh, who said that earlier intervention may be very useful, and as you have said that immunotherapy after a few years may not be very much useful. And we have had hemispherotomy done earlier.
Thank you.
Very good discussion that we had. Thank you, sir.
Thank you very much, sir. Thank you for your inputs.
Hello, can I come in for just a second?
Sure, sir.
I'm Dr. Zahir.
Yes, sir.
Yes, sir.
So I don't know the person who presented this. Dr. Rasmussen was the director of Montreal Neurological Institute.
Yes.
And at that time, he believed in taking out portions of hemispheres for Rasmussen's, for epilepsy. He didn't know the term Rasmussen epilepsy got coined after he died. And after he died, I think now the present literature states that you don't have to remove that much of the brain, because immunosuppressive drugs help them, and ultimately you may land up with a hemispherectomy.
Thank you, sir.
Thank you.
So, Professor CUE, sir?
No other comment. Can I present my patient? Whether you got any comment?
Sir, please go ahead, sir.
I want Professor Zahir. I want Professor Zahir to stay back for a few minutes. This is not a difficult case, but it's an unusual case. I have seen the case, and then it has been operated by Dr. C.V. Shankar. Decreased urine output and abdominal distension on 5th of January 2020. She had frequent small quantity of urination for 1 week. On 5th of January 2020, she had no urine output, and there was abdominal distension for which she was catheterized. After removal of the catheter, she had similar complaints occasionally. At the time, an ultrasound abdomen was done. It showed a large cyst, 5 centimeter into 6 centimeter into 2 centimeter. It was thought to be an ovarian cyst. There was no history of swelling or dimple in the lumbosacral region. No menstrual disturbances. She was referred to Chennai. She was the second child, and it is LACS, and indication of the previous LCS. The birth weight was 3.3 kg. Developmental history was normal. General examination was quite normal. The nervous system examination again was normal. Motor system, cranial nerves, eye functions, everything was normal. The sensory system was normal, including the perianal sensations. The gait was normal. The spines were normal. No tufted hair, no tenderness, no signs of unusual irritation, and no spinal deformity. The routine investigations are normal. Proceed. Proceed. Excuse me for a second. The MRI shows a cyst in the abdominal pelvic region, which is communicating with the spine. I'll show you some more pictures. So you can see that the large cyst which is in communication with the spinal cord. This again one more view. You can see this beautifully. You can see a small area of communication with the spine. So now we'll talk about the surgical procedure. I'll ask the neurosurgeon to talk to you. Salman.
ஒரு செகண்ட் இருங்கப்பா ப்ளீஸ்ப்பா, செகண்ட் இருங்கப்பா, ஒரு செகண்ட் இருங்கப்பா, நீ கூட பண்ணா வராது, இருங்கப்பா.
I will present myself. The general anesthesia, the patient was prone and the patient was sedated and draped. The baseline necessity and the motor evacuations values are recorded. A midline skin incision was made. And from L3 to F3, spinal muscles, the paraspinal muscles were elevated. S1, S2, S3 laminating done. The dura identified. A sacral roots are seen and secured. And there is a depict at the ventral sacral area at S3, S4. Hernia critical site and neck was identified. And the meningocele was decompressed after aspiration and PSM. The sac was delineated and ligated and cut. Homeostasis was secured, wound closed in layers, postoperative MEP and SSP were normal. I'll now show you the procedure. Video. Anyway, I'll do it. The condition on discharge is she has no deficit, able to avoid urine, and post-operative ESG abdomen. Meningocele was not visualized. Urinary bladder and uterus is in normal position. The first case has been reported in 1837. In the 108 years since the first case, the anterior sacral meningocele was described only in about 200 cases. This is the literature. Those who are interested can tell me. I can send you the Indian literature. Hello, K.R. Khan. He has done a picoperitoneation in a case of symptomatic anterior sacral meningocele. He is from West Bengal. Anup Mehta from Delhi is in an anterior sacral meningocele presenting as constipation. Neeraj Bastani had done a successful operative management of giant anterior sacral meningocele by the transabdominal approach in an adult male. Pinkana Paul has shown anterior sacral presentation with purulent rectal discharge, meningitis, and altered mental status. Then I have been asking my friends and nobody could give me better information in our country. I spoke to Dr. Muthukumar at Madurai. He is the one who has been operating on spina bifida, number of cases, and he said he has seen only one case. There is no published literature. Thank you very much.
Thank you, sir. Vijayan, you please
Thank you.
carry on.
Thank you. Thank you.
Sir, Vijayan
you,
wants to
Dr.
say
V.
something. Sir, Vijayan wants to say something, sir.
Yeah, please, please.
Vijayan?
Sir, nothing more. This is the first case. I've never heard of anterior sacral meningeal. The first time I'm seeing one.
Many of us, yes.
Exactly. I've
I
been
never
boasting
knew that it
I've been-
existed. Sir.
I've been boasting that I've been in the Institute of Neurology for 50 years. And I have never seen one.
Thank you, sir. Thank you, sir. Thank you, sir, for
Anybody, Dr. Zahir? Dr. Zahir?
Zahir, sir, are you here?
room la poi
Dr. Zahir?
Zahir, sir, is there? Zahir, sir? Vishwakumar, sir, is there? Vishwakumar, sir, have you seen, sir?
Yeah, I've
Sukumar.
worked with Dr. CUV for 16 years at the Institute. I don't think I've ever seen one case. It's a fantastic presentation. It's a very rare event, rare case, very well managed. Congratulations.
So only one case has been seen by Dr. Muthukumar. As you all know that Muthukumar at Madurai, is Secretary of the Neurological Society of India, and he is an expert in the spina bifida, the dystrophic states. He has seen a number of cases and published them. I made a phone call and he said he has seen one case, but he has not talked about the operative procedures. Any other comments?
Excellent learning case, sir, and beautifully presented. Thank you very much, sir. Beautiful. Really nicely worked up, and outcome is really nice. Thank you, sir.
The thing is that I have not made the diagnosis. The patient is from Myanmar. The neuroradiologist was considered as a cyst, ovarian cyst. The neuroradiologist at Myanmar, we thought is a backward country. The neuroradiologist there had made a diagnosis of the anterior spinal meningocele, and that gentleman has worked for 30 years in England, and came and settled in Myanmar. He has already made the diagnosis sent to me. All that I have only a post box sending it to the neuroscience of the surgical procedure. Unfortunately, I couldn't show the surgical procedure. Video. Is Dr. Zahir there? Zahir?
He is there.
He is there.
Oh, let him make his comments on this. Dr. Zahir? So I thank Dr. V. Natarajan.
Sir, no, UMS, sir, UMS is there, sir.
No. I just wanted to thank you for allotting this to Chennai.
Sir, please don't say. We should thank you for bringing in such a very rare case and showing it us. Thank you, sir.
So UMS.
Sir.
You can
Final words, UMS, your vote of thanks.
Sir, I would like to thank everyone, sir, from the youngest Professor CUV, who has always shown us.
No, there are further younger people, Zahir Ahmed and
yes, sir.
Professor G.
Professor GA. Yes.
So they had more younger work, so they had to leave also. So Professor J had already told us. Zahir left. So you are the youngest remaining in the group now, sir. So thank you very much, sir. And thank you, Professor Vian. Vian, sir, kindly allow
Not
more
for me,
time
but
for Chennai people also, sir. Sir, kindly allot more sessions for Chennai people also, sir.
Everybody should get a chance, sir.
I would also
You, my
like to
sir, everybody should get a chance, sir.
Yes, sir. Yes, sir. Chennai people are
Chennai
not giving
always,
chance at
Chennai
all, sir.
always gets a chance.
We used to, sir. Last 1.5 years, we have not had any opportunity. So
Yes, sir. We will do
I'm
it,
sure
sir.
everyone is looking for opportunities. Thank
We
you,
will
sir.
do it, sir. We will do it.
Thanks to everyone for, yes, sir. Thanks for everyone. Thanks to everyone. I think we had more than 55, 60 people, which is very good on a Sunday morning.
No, more 87.
87 as a maximum, sir. Yes, sir.
To thank the presenters, Dinesh, Viswanathan,
Yes, sir.
Srivardhan,
Even though
Malcolm,
I'm sure it was
Glenn's
not
Mellon
planned, it
unit.
turned out to be a masterclass in epilepsy. So thank you very much to every one of you for those wonderful cases.
And the first case from MIN.
Yes, sir. Also ultimately turned out to be a myoclonic epilepsy. So the discussion was epilepsy today, and it was wonderful, sir. Thank you all. Thank you very much, sir. Thanks for the opportunities.
Thank you, sir. Thank you, Sun Pharma. Thank you.
Thank you very much.
Thank you, Jyoti.
Thank you, Sun Pharma, for sponsoring this. Thank you very much. Thank you.
Thank you.